Darshna Dhania. He's an associate professor of medicine at Cornell and also medical director of the Histo-Incompatible Kidney Transplant Program and assistant director of Immunogenetics and Transplantation Center at Cornell. And she'll talk about BK nephropathy. So welcome, Dr. Dhania.
Okay, welcome everyone. Thank you, Dr. Telda and colleagues, for the invitation to speak today and share some of the updates on BK virus nephropathy. So as you know, BK virus is a double-stranded virus that is a member of the polyoma viruses. Both JC and BK can affect the human host. The virus genome consists of 2 regulatory regions, large T and small T antigens, and 3 virus peptides, capsid proteins, VP1, VP2, and VP3. And there are 4. So for my presentation, I have no conflicts of interest. Some of the management strategies for BKVN fall under the category of off-label use. As we were speaking about the BK virus, there are 4 major serotypes in which groups 1 through 4 and consists of additional subgroups as well. And each one has been associated with BKV replication in the human host. So exposure to BK virus occurs early in childhood, as you know, earlier than JC virus, usually through the respiratory tract, and remains latent in the epithelial cells of the urinary tract system. It's been associated with hemorrhagic cystitis, nephritis, as you see here, and recent reports actually of malignancy within the GU tract. So when the BK virus infects the transplanted kidney, in the setting of over-immunosuppression, replication ensues, leading to lytic destruction of the renal tubules, influx of inflammatory cells causing damage to control the virus replication, and perhaps even ends up being an allograft response, causing parenchymal damage and then allograft dysfunction. This is data from the OPTN registry, just kind of showing the incidence of BKV replication or episodes where management had to be started for BKV replication. This was only from 2002 to 2006 because now UNOS does not collect data on whether there was a BKV-related complication in the post-transplant setting. And as you can see, from 2002 to 2006, the incidence of BKV replication or complications was increasing from the percentage being 1.53% to 6.41% in 2006. And even if you look at the months post-transplant, the overall incidence increased with time. So there were new cases where there was BKV replication and injury to the allograft. In terms of the natural course of BKV infection, one of the first studies that was published in the New England Journal by Dr. Hirsch et al., he studied viruria, viremia, and nephropathy. And he demonstrated that the replication is first detected in the setting of viruria, and then subsequently viremia, and subsequently nephropathy. And the incidence of viruria exceeds the incidence of viremia, which exceeds the incidence of nephropathy. So not everyone who has BKV replication develops nephropathy and allograft injury. We studied urine BKV VP1 during the first year post-transplant and demonstrate the peak incidence of viral replication using this assay was at 6 months post-transplant. And you can see the dynamic changes that occurred. Not everyone that was positive at 1 month post-transplant for BKV replication remained positive at 6 months post-transplant. So the day-to-day management and day-to-day exposure of immunosuppressive drugs actually influences whether replication persists or goes away and comes back. And this was the study without any intervention. Risk factors for BKV replication in transplant recipients. I think the significant associations are with the immunosuppressive therapies. So corticosteroid therapy in terms of acute rejection therapy or maintenance corticosteroids both have been associated with an increased risk of BKV replication and nephropathy. Newer immunosuppressive agents, specifically the combination of tacrolimus and Cellcept, has been shown in multiple studies to have a higher incidence of BKV replication in the post-transplant setting. And induction agents, specifically T-cell depleting agents, have been associated with an increased risk. Other possible associations that have been studied include HLA mismatches, specific HLA alleles, such as the HLA-C7 allele, deceased donor grafts, and older donors. Those 2 variables get at the theory of a second hit in BK virus nephropathy. So there's already injury when you have cold ischemia time, and if the virus is traveling with the donor graft, there's a higher risk of BKV replication in that recipient. Male gender has also been associated with a possible increased risk of BKV replication, as has diabetes and the presence of a ureteral stent, which I think now has 3 studies. 2 of them say that it is a risk factor, 1 of them stating that it's not. So in terms of the large cohort, the largest cohort that looked at risk factors for BK virus nephropathy or BK virus complications post-transplant is this OPTN registry data, where they looked at matched kidneys. So they were deceased donor kidneys. 1 kidney went to an individual who never developed a BKV-related complication, and 1 kidney went to an individual who did develop a BKV-related complication. When studying those recipients, the risk factors that they identified for BKV treatment is how it was worded, the data form. By multivariate analysis, it was age, male gender, HLA mismatch, acute rejection treatment within the first year, and induction with depleting antibodies that came out as the strongest risk factor for BKV replication and injury. And on the right, you see here the graft survival of those patients who developed a BK-related complication. So all of these patients actually were analyzed if they had a functioning graft at 1 year post-transplant. And then they looked at these matched kidney recipients and those that developed a BKV complication, what their graft outcome was compared to those that didn't. And as you can see, just having a complication related to BKV is associated with significantly increased risk of graft loss at 5 years post-transplant. So in this presentation, I'll briefly review the diagnosis, prevention, prognostication, and management of BK virus. In terms of diagnosis, histological diagnosis still remains as the gold standard. Within the histological diagnosis, you must have positive immunostaining for the BK virus. That can be performed with a BKV-specific probe or the SV40 probe. And the pathology that you see in BKV nephropathy is cytopathic changes, which are the tubular epithelial cells with the viral inclusions causing, I don't have a pointer, but on the left-hand side is stage A, and you see the cytopathic changes with the dark purple ring and the lighter blue intranuclear inclusions, inflammation as a response to the viral infection, and fibrosis. So all of these findings were found in all these kidney biopsies that were studied, and based on the findings and the clinical outcomes, there were stages of BKV that were identified. So stage A is an early stage where there's mild cytopathic changes, less than 10% inflammation and less than 10% fibrosis. Stage B is where there's a moderate degree of cytopathic changes and moderate degree of inflammation. Generally, the fibrosis is not that advanced, less than 30%. And then stage C is when there's extensive fibrosis greater than 50% with variable degrees of inflammation and variable degrees of cytopathic changes because the kidney's kind of burnt out at that point and is associated with poor outcomes. So histology being the gold standard and a BK virus being a dynamic process that you need to monitor regularly. There are various efforts put into looking at non-invasive diagnosis of BKV replication, and the earliest efforts looked at urine cytology. So they performed electron microscopy to look for BKV virons, which is what you see at the top there, as well as other assays called the decoy cells, which is a cell that contains the intranuclear inclusions with the viral particles, which you see on the left-hand side there. And then more recently, Hoffen, which is basically a tubular cast of cells that are infected with the BK virus. So those are all cytology-based, and then we have molecular assays that have been developed in the urine and the plasma, and they're DNA, or the one that was developed at Cornell is an mRNA-based assay, and then the plasma PCR assay for all the vendors that are available is a DNA-based assay. So this study kind of summarizes the characteristics of the different assays that are available to you to diagnose BKV replication or nephropathy. To date, there are very few studies that have correlated the non-invasive assay with the pathology. And in this study, Singh et al. Looked at 40 patients who had histological diagnosis of BK virus nephropathy and studied all of those 4 assays, the Hoffen, the decoy cells, the urine BKV DNA, and the plasma BKV DNA. And they identified what the sensitivity and specificity was for diagnosing BK virus nephropathy as determined by pathology. And you see the positive predictive value as the negative predictive value listed as well. And what you can see is that every assay has a great sensitivity, every assay has a great negative predictive value. So if you have a negative assay, that's great. The plasma BKV DNA, I'm not sure which vendor they used in this study, but it was a little bit lower, 88% compared to the 100%. And the specificity and the positive predictive value was highest for the Hoffen, which is an assay that they developed at their center. I put the assay that we developed at Cornell just to contrast with the others that are available, since that was not studied in the cohort. And we studied 92 patients in a validation study, followed by the initial 88 patients that we had studied. So that's why the numbers don't match. Sorry about that. The sensitivity was, again, 100%, and negative predictive value was excellent. But our specificity and positive predictive value matched, similar to the Hoffen diagnosis. However, you should be aware that there is a lab-to-lab variability in BKV assays. So we do have our research urine mRNA assay, but we also do send the plasma for DNA assay. And we had noticed at some point during one of the studies where we were looking at mTOR inhibition that the copy numbers that we obtained from New York Hospital, which is our hospital, compared to the vendor was drastically different, almost a 10-fold difference. So I just kind of share the information with you because you may or may not be aware of this data. I don't think this data is there. So the median value using the NYP assay is 470 copies. The mean was 6,000 in contrast to 12,000 in the Quest assay, and 159,000 is the mean in the Quest assay. So there is an effort to standardize this assay. The WHO, similar to the CMV assay, WHO has gotten together to develop an international standard that can be used to quantify the BKV assay. The standard contains multiple subpopulations of BKV, and the viral quantification can still vary up to 4-fold depending on where your primers and probes target the genome. And this, whether the standard would be or would not improve this variability in lab-to-lab was studied by Tan et al. So they took 2 commercial assays that at baseline differed by 0.7 log. They used the international standard to recalibrate their data, and using the WHO standard, the agreement between the 2 assays improved significantly, and the copy difference, the absolute copy difference, reduced from 0.7 to 0.1 log. And there was also a systemic improvement. There was improvement in the systemic bias that existed in these 2 assays. However, at this point, I'm not aware of this being a standard that is a required standard across different laboratories. But hopefully, we will get there. So prevention, having the diagnosis of BK virus nephropathy, knowing that it's associated with poor outcomes, and having non-invasive assays that can detect BK virus replication earlier and prior to nephropathy. Prevention would be an important goal in managing BK virus infection in our transplant population. So just to review the different studies that could guide our management, this is a nice slide that kind of demonstrates the time course from viuria to viuria plus viremia, viuria plus viremia plus nephropathy. You rarely have nephropathy without the viuria and viremia. So this is a longitudinal time course post-transplant. And Dr. Hirsch and colleagues kind of came up with this timeline and named the different phases. So in the first phase, they called it preemptive intervention because you didn't have graft dysfunction, you just had viral replication in the urine or low level of BK virus copies in the blood, and the risk of graft loss or complications was less than 15%. In the second phase, they called it obligatory intervention because there was some graft dysfunction, there were high levels of BKV copies in the blood, and there was a potential for increased risk of developing BK virus nephropathy. That group had an obligatory intervention and graft loss rate of 15 to 50%. And finally, the last group, all the way at the end, where you have significant fibrosis, significant graft dysfunction, they called it end stage, and it was associated with poor allograft survival despite viral clearance. I'm going to review two studies that kind of take a look at the strategy for monitoring patients with a blood-based assay and a urine-based assay. So this is from Dr. Hirsch and colleagues as well. It's preemptive reduction in immunosuppressive therapies using the plasma BKV assay. So they had a total of 206 consecutive patients, so that's the nice part about the study. It's a very large cohort. And in those patients, they identified patients who had low levels of BK viremia, very small number, 8. That was less than 10,000 copies in the blood. They coined the term presumptive BK virus nephropathy, or PVAN, which is 10,000 or higher copies of BKV in the blood without histological diagnosis or graft dysfunction associated with BKVN. And then PVAN, where there was graft dysfunction, there was histological evidence of BKVN and high copies of BK viremia. So as you can see, the serum creatinine is a little bit higher in the group that had PVAN or BKVN diagnosis compared to those that only had presumptive or low level viruria. But what's interesting is that if you intervene at the earlier stage, low level of BK viremia, you have 100% clearance. And if you look at the bottom, the rejection risk is small. Only one person developed a subsequent rejection episode. In the presumptive cohort, 15 out of 17 cleared with reduction in tacrolimus and subsequently additional reduction in tacrolimus, 15 of 17 cleared, and then no additional benefit was obtained with CellCept. In that cohort, the rejection rate was 4 out of 17. So reduction in immunosuppression is associated with a potential risk of increasing acute rejection episodes, despite not having biopsy-proven BKVN and high copies of BKV in the blood. PVAN, in that cohort, there were 13 patients. With step 1, only 2 out of 13 cleared. With step 2, only 8 out of 13 cleared. Step 1 and 2 are the TAC targets that you see there. And step 3 was a 50% reduction in CellCept that led to 12 out of 13 clearing their BK viremia. But the rejection rate is still there. 5 out of 13 developed rejection on follow-up. The 33-year outcomes were pretty good. The serum creatinines were 1.6, 1.6, and 1.3. So this was, an effective strategy as monitoring patients with BK viral replication, reducing immunosuppression in a stepwise approach, tacrolimus 6 to 8, tacrolimus 4 to 6, and then 50% reduction in CellCept. But it still was associated with an increased risk of acute rejection. And this is a more recent study that looked at using just the urine. So they didn't monitor patients with BK viremia, they just looked at viruria. And in their cohort, which was not a controlled trial, but they looked at everybody that was transplanted at their center, they were monitoring them at BKV viruria at 1 month and then every 3 months thereafter. And they identified patients into different groups. Group A had viral copies that were less than 10 to the 4th. Group B had viral copies between 10 to the 4th and 10 to the 7th. And Group C had viral copies that were greater than 10 to the 7th in the urine. And that Group B was a group that had viral copies greater than 10 to the 7th, but they decided not to change any immunosuppressive therapies because they were at high risk for rejection complication. So we're really looking at the CA group where they reduced immunosuppression sequentially, and they achieved, if you look at the bottom, in terms of clearance, 62% of the patients received viral clearance. But if you look at the bottom, the nephropathy rates were 15% in that same group, the CA group. So despite reduction in immunosuppression, a small cohort of patients went on to develop nephropathy. In the groups that had copies less than 10 to the 7th, nobody developed nephropathy. And then if you look at the acute rejection rates were at 10%, similar to what Dr. Hirsch's colleagues found after reducing immunosuppression. Group A, as I said, this was not a match study, so Group A was already at high risk for rejection and graft loss. That's why you see the 24% rejection rate. They had a higher degree of sensitization and HLA mismatch. So using the urine to monitor BK viral replication and reduce immunosuppression can be helpful as well, but it's associated with the same complications as with monitoring viremia, which is acute rejection. The nephropathy incidence is a little higher than you would expect if you were monitoring using the blood assay, because most of the current studies that have looked at prospective monitoring of urine BKV viremia have demonstrated that they are able to avoid nephropathy with a 0% incidence. So we have the assay to monitor for replication, and we can intervene early to prevent BK virus nephropathy. However, we know that still a certain proportion of patients will go on to develop nephropathy. So in that cohort, what is it that we can use to kind of see which way we should head? Is it the rejection that's going to hurt that kidney, or is it the nephropathy that's going to hurt the kidney? So we wanted to kind of study prognostic markers, and the prognostic markers that we have, the first one is the histology that I already told you about, and I just put in the graft function and the risk of graft loss associated with the different stages of BKV here, with stage A being less than 15%, B1 being 25%, B2 50%, B3 75%, and with stage C greater than 80% of proximate graft loss. But what we really need is some immune markers that kind of tell us what we should do with our immunosuppressive therapy. So I chose to give you an example of BKV-specific immune responses that are tested in the blood. And on the left-hand side, you see it's just case reports, 5 patients who had very high viral load of BKV copies. You see it up there, 1 million to 250,000. Each of those 5 patients that had high copies of BK virus in their blood had evidence of virus-specific T-cell immunity that was higher than control cohort. They studied one patient with rejection to see if this BK-specific T-cell response is nonspecific, and actually that patient did not have any T-cell specific, BKV-specific T-cell response, but had allo-specific T-cell response. They subsequently did a later study of a series of patients where they kind of demonstrated what happens to these CD8 positive T cells that are responding to the BKV viral proteins. And so on the right-hand side, I don't have a pointer to show you, but I'll tell you at the top is the immunosuppression and the change in immunosuppression. So once the BK viremia was diagnosed, which is the bottom panel, you see the BKV load going up. They changed the CellCept to azathioprine. They changed the tacrolimus to cyclosporin. And what you see in the middle 2 panels is that the BKV-specific immune response to the BKV proteins VP1, VP2, VP3, and the small and large D antigens, which was non-existent, started to go up as the immunosuppressive reduction was introduced. As it started to go up, you see at the bottom that the BK virus clearance began. So they associated the T-cell immune response with clearance of the BK viremia in the bottom panel. There was also a humoral immune response in terms of the IgG levels going up. So perhaps in our patients where we want to prevent the nephropathy, we want to prevent the rejection, this is one assay that could be utilized as we're reducing immunosuppression to see if we need more reduction in immunosuppression because there's not an adequate T-cell immune response against the virus, or we can continue the status quo and we expect to see a subsequent decrease in BK virus, and we don't want to increase the rejection complication. Another prognostic marker that could be utilized is to know at the time of BKVN diagnosis what is going to happen. Is the kidney going to survive long term, or is it a high risk for proximate graft dysfunction? So we studied BK virus nephropathy at the time of initial diagnosis in 18 patients. 8 of them had declining function during the subsequent 12 months, and 10 had stable graft function long term. To look at the urine markers to see if they would be informative in terms of identifying patients who would be at risk for declining function, where we perhaps needed more immune therapy because there was an anti-allograft response that was ensuing. There were no baseline differences between the cohorts. I'm sorry, my slides I forgot to switch. So in those 18 patients, what we noted is that if you look at the urine T-cell cytotoxic molecules, granzyme B and perforin, those molecules correlated with the rise in serum creatinine during the subsequent 12 months. So those were that at risk for graft dysfunction had higher levels of cytotoxic T-cell molecules in the urine at the time of BKVN diagnosis. So perhaps this is a cohort of patients that you would intervene differently, provide immune modulatory therapies such as IVIG or other agents to kind of avoid the subsequent decline in graft function. The bottom two panels are the BKV, VP1 mRNA levels and the housekeeping gene 18S RNA, which showed no correlation with the subsequent decline in graft dysfunction. And if you just look at the BKV cohort, you can actually break it down into tertiles. So those that had the highest levels of granzyme B, the middle tertile, and then the lowest levels of granzyme B. The ones that had lowest levels of cytotoxic T cell molecule granzyme B had 0 out of 6 individuals who had declining function or graft loss. In the middle tertile, half of them had declining graft function, and 1/3 went on to develop graft loss. And in the highest tertile, 83% had declining function, and 67% went on to graft loss. So this is a group of individuals where you could identify potential therapy and intervene early at the time of BKV nephropathy. We also studied fibrosis-related markers in this cohort. This is an independent from the 18 that were studied before. This is a group of 29 patients where we looked at graft loss specifically, because in the previous study, as you noticed, the graft loss trend did not reach significance. Here we looked at fibrosis-associated markers. So we studied PI1, Vimentin, TIMP1, and fibronectin, and compared these levels at the time of BKVN diagnosis and see if they would predict what was going to happen to their graft. And in fact, there was a high degree of correlation between those that experienced graft failure within 3 years of the BKVN diagnosis compared to those that didn't. So the PI1 levels, the Vimentin, fibronectin, and TIMP1 were significantly elevated compared to those that did not experience graft loss. And on the side, you see the validation data for the granzyme B and the perforin. And so from that data, we came up with a model based on clinical parameters, which included serum creatinine, the urine cell PI1 mRNA, and the biopsy findings. And if you did the ROC curves, looking just at the non-invasive markers, biopsy and creatinine and PI1, compared to biopsy, creatinine, and PI1, there was no difference in the AUCs. And the sensitivity for this assay was 100% and specificity was 89%. Since then, we've actually validated this study in an independent cohort to see if PI1 is still a predictor of graft loss, and we found our data to be consistent with our initial findings. Another prognostic indicator following BKV replication or infection or reactivation is development of donor-specific antibodies. So there's a new literature, I think recent, that demonstrates that the BK viremia is associated with increased risk of de novo DSA, hazard ratio of 2.55. As many as 32% may develop DSA following BK viremia by 6 months. In our cohort, we looked at our patients who had presumptive diagnosis as well as histology-proven BK virus nephropathy. Combining those two cohorts, we had a total of 79 patients. Of those 79 patients, 17 experienced decline in graft function at 1 year. So we performed an analysis to find out the risk factors for declining graft function, and that's the multivariable analysis that you see there. And the two variables that stood out was serum creatinine and the development of donor-specific antibodies. In this analysis, we did not include the urine biomarkers, but development of donor-specific antibodies following BKVN diagnosis was a significant risk factor. And 14 individuals developed graft loss, and using Kaplan-Meier analysis, which I didn't make a slide of, there was a significant association with the development of DSA post-BKVN. So we spoke about monitoring, we spoke about determining prognosis. Maybe the prognostic markers also helped elucidate how to develop a management strategy for patients who develop BK virus replication or nephropathy following transplantation. And so I thought I would review for you the current data that exists with the different therapies. So reduction in immunosuppression is the cornerstone still. There's no specific antiviral therapy. However, there's been a lot of studies that looked at in vitro studies to inhibit BK virus replication. So they've studied cidofovir, they've studied brincidofovir, which is a lipid conjugate of cidofovir, which has been shown to have increased in vitro activity compared to cidofovir by blocking DNA viral replication. Leflunomide, which inhibits protein kinase activity and pyrimidine synthesis, has been shown to inhibit large T antigen expression, as well as DNA replication, as well as virion assembly. Fluoroquinolones that inhibit helicase activity of large T antigen and BK DNA replication. And then mTOR inhibitors, which bind to FKBP12, leading to inhibition of the mTOR pathway, which decreases the BKV progeny release in the early phase of BKV infection. It's also been shown to reduce the large T expression. So I try to summarize the studies that are out there. There are some systemic reviews that have been performed. At the top is a systemic review that looked at 555 publications. Out of those, 40 met the inclusion criteria. And the strategy they categorize into immunosuppressive reduction with cidofovir, immunosuppressive reduction with leflunomide. And they actually had some studies that used IVIG, but not enough to summarize in a table format, so they just kind of reviewed the data. Here I have the number of person years studied and the rate of graft loss. As you can see, amongst the three strategies, there's no significant difference in the rate of graft loss. 8 per 100 patient years with just pure immune reduction, and similar if you added cidofovir on top of it, and similar if you added leflunomide on top of it. At the bottom is a review of case series from 2002 to 2008, and just looking at cidofovir, leflunomide, and IVIG. The next column tells you the number of reports that were studied, and then in parentheses the number of patients. And then you see the end result, which is viremia clearance, which is about half, no matter which one of those strategies you use. And then all the way to the right is the graft loss, which was 23% cidofovir, 17% leflunomide, and slightly lower, 7%, but not statistically different. So mTOR inhibition and BKV, I just thought, since there's a lot of emphasis in the literature that may be the strategy to go with in terms of maintenance immunosuppression if you wanted to totally avoid BKV-related complications. So I reviewed some of the studies. This is registry data, retrospective studies, and observational studies. And you can see that the data are still conflicting. It's not a consistent message that's out there. So within the registry data, one study suggested that it was beneficial to be receiving mTOR-based therapy. It's associated with decreased incidence of BKV treatment, while the other study did not support those findings. In the retrospective study, I chose a couple of the largest studies that were out there. The first one is 518 de novo kidney transplant patients. And in that patient, they compared tacrolimus with sirolimus versus tacrolimus with CellCept, and they found no difference in BKV-related complications. The second study is a 3-year study from 2008 to 2011 of 180 kidney transplant recipients. There they had initial maintenance therapy as tacrolimus with CellCept or tacrolimus, CellCept, and prednisone, and their strategy was in some of those patients to replace the tacrolimus with sirolimus at 3 months post-transplant. So in that third group, the BK viremia was only 4.3% compared to 17 and 19% in the other two groups. So there was a trend towards benefit in that study. The observational study was 296 de novo patients. 58 received everolimus, cyclosporin, and prednisone versus the rest who received cyclosporin, CellCept, and prednisone. And there was a trend toward benefit in terms of BK viremia being 9% versus 22%. There was also a trend towards lower incidence of graft loss in the everolimus group. So there may be a signal there, but there's not a randomized controlled trial that definitively tells us which way we should go. There are 2 meta-analyses that also looked at mTOR inhibition-based therapy. So the first comparison was made with mTOR inhibitors with CellCept plus or minus steroids versus the CNI and CellCept plus or minus steroids. And the risk of BKVN was 0.71, crossing that one line, so not statistically significant, but maybe a trend towards benefit. The price that you had to pay was the risk of acute rejection, donor-specific antibody development, or graft loss, which was a composite endpoint, was statistically higher, 1.39. In comparison to, they used mTOR inhibition with low-dose calcineurin inhibitor versus calcineurin inhibitor and CellCept, and there were 3 trials that were included in this meta-analysis. And again, the risk of BKVN was lower, 0.57, but crossed that line, so not statistically different, but a wide confidence interval. And then in terms of the risk of acute rejection and graft loss, there was no significant difference between that group. So both studies suggesting that there's a trend toward benefit in terms of BKVN, but one study saying that you're going to pay a price, the other study not conclusive. The other agent that's been used to manage BKV, and actually is the only agent that's been studied in randomized controlled trial, is the fluoroquinolones. So they studied in the use of a prophylactic therapy, 3 months of levofloxacin versus placebo in 154 patients. They looked at BK viruria at 1 year. It was 29% versus 33%, not different. Treatment of BK viremia was also a randomized controlled trial using levofloxacin versus placebo for 30 days. 39 patients. Reduction in BK load was 58% versus 67% 1 month, and then 82% versus 90% at 6 months, not statistically different. So at least we can say fluoroquinolones alone is not something that we need to kind of consider in our management. These are randomized controlled trials that demonstrate no benefit. There is another trial that's looking at the combination of leflunomide and sirolimus-based therapy, and there's no preliminary data that I saw in the literature as of yet. IVIG, as you guys all know, in terms of managing DSAs and sensitized patients, there's multiple different mechanisms of how it's beneficial in immunoregulatory. It can regulate the innate response, the adaptive immune response. It can actually facilitate expansion and enhance function of regulatory T cells. And actually, there's been studies that have shown that IVIG itself, derived from healthy individuals tested in vitro, co-incubated with BKV infected cells, can lead to 90% reduction of viral DNA. And there's no data, and in the literature currently, there's a lot of small case series. There's no randomized controlled trial of IVIG for the management of BK virus nephropathy, and actually there's not a meta-analysis out there either. So I chose one study just to kind of share with you. It's a study cohort of 53 patients who developed BK viremia, low copies, greater than 500 copies. 23 of the 53 had viral clearance, not surprising because the copies were low, with immunosuppressive reduction. The remaining 30 patients had persistent viremia, and then 20 developed presumptive BKVN, and 10 developed a biopsy-associated BKVN. And they were treated with 1 gram per kg of IVIG, 1 to 2 doses, and the results show that there was a significant reduction in BK viral loads. 90% had viral clearance. 2 patients developed rejection, and graft survival was 96.7%. There are other studies that suggest that treatment with IVIG may actually lead to an increase in viremia, case series or case reports. So there's data on both sides. For our center, I didn't make slides of our data, or I actually had the slides, but I took them out because of time. Our approach is to use IVIG to address the inflammatory response related to BK virus infection, and then to use leflunomide to substitute for the cell steps. So combination of IVIG and leflunomide is what we've used, and we've noticed that the clearance is better, graft function is stabilized, and actually there's a trend towards improved graft survival in that cohort compared to those who get another approach. Not a randomized controlled trial, though. And then what's really interesting, sorry. Okay. And then what's really interesting, I think, is the new therapies that we're learning about from the hematopoietic stem cell transplant population. They actually have been stimulating T cells with viral peptides in a petri dish, and then expanding those virus-specific T cells, and then infusing them back into patients. And they've done this for CMV, EBV, JCV, and BKV in their patient population. Their patient population is slightly unique because it's just a host immune HLA response. We have the donor HLA and the host HLA to deal with. But using third-party donors, they've actually presented preliminary results at a recent meeting that are encouraging in terms of clearance of CMV viremia. Data looks very good in terms of EBV. And BK, there's just less than 10 patients that have actually been studied. But there's some signal that it may actually be beneficial. So maybe we'll learn something from them, but I think that we'll actually have more questions because of the interplay between the host and the donor immune cell and HLA repertoire. Okay, so that was my last set of data, and then I thought I would quickly summarize for you what I went over. And BKV replication occurs commonly in kidney transplant recipients and still associated with significant risk of graft dysfunction. So in terms of diagnosis, histological diagnosis remains gold standard. Presumptive BKVN can be diagnosed using the non-invasive assays, but there's a great need for standardization of these non-invasive assays across labs so that we can compare similar patients and similar treatment strategies. In terms of prevention, preemptive monitoring is feasible, affordable using blood and urine assays. Early intervention based on blood levels is associated with improved overall responses. Validation of management strategies using cellular immune responses in blood and urine may be of value to avoid subclinical rejection, and that requires further studies. In terms of prognostication, renal function at the time of BKVN diagnosis is an important prognostic marker. I didn't emphasize that during my talk, but serum creatinine itself is an important biomarker of how well the kidney is going to do. Increased T-cell immune response and development of donor-specific antibodies are associated with increased risk of graft dysfunction, and elevation of fibrosis markers in the urine or biopsy are associated with increased risk of graft loss. So perhaps newer agents that address fibrosis would be of value. In terms of management, reduction in immunosuppression and close monitoring remains the gold standard. In vitro data suggests there may be many options for BKVN. However, there's no robust clinical studies except for the fluoroquinolones. No clear benefit of using leflunomide or cidofovir, even though I use it. Randomized controlled trials of fluoroquinolones have not demonstrated a benefit. mTOR inhibition may be helpful. There's a signal there for sure, but it has to be balanced with the risk of rejection. And IVIG, I think, may be an important agent to control the inflammatory response and may be associated with decreased risk of graft loss. I think that's the trend that I noticed through the studies that we've reviewed. Cell-based therapy may have a future role in the management of our patients, learning from the stem cell patient population. And development of BK virus-specific therapies, I think, we have to come up with new ideas and new targeted therapies. And if we study the molecular pathology associated with BK virus nephropathy, maybe there are new targets that can be identified. And I didn't discuss retransplantation, but it remains a good option for managing ESRD in patients with a failed kidney transplant following BKV infection. Thank you.
Thank you for that talk. Our next speaker for the session is Dr. Bamboula, who is Associate Professor of Medicine, and he's the Chief of Pediatrics here at SUNY Downstate. He'll talk about anemia after kidney transplant.
Yeah, I'm going to be talking about anemia after kidney transplant. From my interaction with transplant providers, there seems to be this impression that anemia after kidney transplant is not a significant clinical problem. So in the next 30 minutes, I'm going to try to disprove that notion. We need to be paying more attention, to this clinical entity. So there is a wide variation. So in 2001, American Society of Transplantation actually adopted the WHO definition for the general population. So that hemoglobin, less than 12 grams, in women, and hemoglobin less than 13 grams per dl in men, as well as postmenopausal women. The cutoff point for hemoglobin is graded by age, for those who are less than 15 years of age. However, most studies use hemoglobin that ranges from 11 to 12 grams, just like we do for most patients with CKD, irrespective of the age and gender. And of 662 American adults, prevalence rate was about 72%, at the time of transplantation. There seems to be a progressive decline in the prevalence rate of anemia with increase in post-transplant duration, such that you have about 40% at 3 months and 20% by 1 year. Prevalence is even much higher, in children, than adults, such that in 162 pediatric kidney transplant recipients, 84% had anemia at the first month after post-transplantation, and 64% by 6 months to 6 years. There is, however, paucity of evidence-based data on post-transplant anemia. Therefore, KDICO recommends guidelines that are practically similar to that of pre-dialysis chronic kidney disease. But we all know that there is evidence to support that these are two different clinical entities. In fact, there is about 10-fold greater incidence of anemia in kidney transplant recipients with similar grade of creatinine clearance compared to patients with CKD. In addition, a peculiar set of multifactorial etiology tends to determine the anemia that we have in kidney transplants. And because of this confusion, there seems to be uncertainty in physician approach to both diagnosis and treatment of post-transplant anemia. In fact, in a survey of European registry with about 6,000 patients, prevalence rates at 3 months was about 42%. Now, there was a similar survey of prevalence rate in the same cohort, about 5 years later, and they still found that they had, the same prevalence rate. This tends to point to the fact that there is a lot of inattention by, for medical intervention by transplant physicians. There is, however, adverse consequences, for post-transplant anemia, such that, despite improvements in graft survival, a major challenge is to minimize, cardiovascular morbidity, and therefore to curb the death rate, with functioning grafts. Perhaps by paying greater attention to anemia control, we may be able to address a lot of this shortcoming. And in Renaissance trial of non-renal patients, there tends to be 16% reduction in cardiovascular mortality for every gram that is gained in hemoglobin mass in elderly patients. There is, however, limited data of high quality in kidney transplant population. In fact, there are no randomized control trials. In retrospective studies, however, early or late onset post-transplant anemia tend to be predictive of graft loss and mortality rates. However, this relationship is confounded in those who have graft loss most of the times when you look at prospective studies. And in our large trials, which is a prospective studies, anemia was predictive of graft survival, but not mortality rate. Now, in a study by Chabra et al., in CJC in 2008, Kaplan-Meier graft survival by categories of hemoglobin deficits showed lower graft survival rates in patients with hemoglobin that is less than 11 gram per dl compared to those who has greater than 11 gram per dl hemoglobin. This finding, however, is confounded by chronic graft loss, as there is greater prevalence rate of anemia with increasing loss of graft function. 30% of patients actually with moderate anemia has 30 to 60 cc per minute of GFR, compared to 55% for those who has GFR that is less than 30. Similarly, 5% of patients with severe anemia has a GFR of around 30 to 60, compared to 36.4% for those who has severe loss of GFR. In a recent prospective trial that was deliberately designed to control for the confounding effects of chronic graft dysfunction, after about 10 years of follow-up, severe post-transplant anemia was predictive of 6 to 10-fold higher mortality rates in those with early and late-stage chronic graft dysfunction, respectively. And as illustrated in this diagram, a 6-fold increase in mortality rate is associated with severe post-transplant anemia in those with transplant CKD stage 1 to 2, compared to 10-fold increase in those with transplant CKD stage 3 to 5. If you look at transplant CKD stage 1 to 2, on the left hand, you will see that there is greater impact of severe anemia on mortality rate compared to that of the mild anemia. This is an evidence of an independent effect of anemia and CKD, on mortality rate. In addition to mortality rate and graft failure, prospective trial seems to suggest that there is lower quality of life index in patients with a greater degree of anemia. And using kidney disease quality of life questionnaire, Abashi et al. Show that there is lower score on mental health domain in patients with post-transplant anemia as compared to the control. This is despite similar burden of chronic kidney disease in the two groups. The effects of kidney disease and symptoms and problems associated with kidney disease is also similar in both groups. If there are consequences for post-transplant anemia, this opens an argument for treatment. If treatment is required, then what is the hemoglobin target that we'll be shooting for? Shall we normalize hematocrit in every patient with post-transplant anemia? Or shall we try to attain maybe 10 to 12 grams per DL as we do for patients with CKD? There seems to be a biological reset in optimal hemoglobin target in individuals after post-transplant anemia. And this reset seems to be affected by a mixture of variables, such as the use of steroids, immunosuppressive agents, and delayed graft function. And besides, when do we initiate treatment? We do know that there is variable dilutional anemia in the first few days of transplant surgery, depending on the proclivity of the transplant surgeons to use IV fluid. And also, we know that at variable times, some patients will recover from iron deficiency with adequate nutrition, even in the absence of iron supplementation. And what is the appropriate modality of treatment? We know that it's going to be different in early onset anemia compared to the late onset anemia because they have different pathophysiological basis. So we do know that in early onset anemia, universal erythropoietin is not cost effective in the first few weeks of surgery, in the first few weeks of transplant, because early onset anemia is predominantly due to iron deficiency. And as for the late onset anemia, there seems to be conditional response to erythropoietin. In one study, there are two ill-defined groups. 90% has low endogenous erythropoietin, apparently from impaired graft function, and they tend to require low-dose recombinant human erythropoietin for correction of anemia. Another 10% has a high endogenous erythropoietin level, most likely from bone marrow resistance, and they tend to require larger doses of recombinant human erythropoietin. The etiological factors for such bone marrow resistance can be guessed by every one of us. It includes things like nutrient deficiency, immunosuppressive agents, use of ACE inhibitors, and persistent microinflammatory syndromes that tends to associate chronic graft dysfunction. And if you're going to be using erythropoietin, we all know that there is a fear of harmful effects of anemia control in patients who were given erythropoietin stimulating agents, similar to what we have in CKD trials, such as QUIRE, CREATE, and TREAT. In fact, there is an European registry study that tends to show similar findings to what we have in CKD trials. And in these studies, it showed there is a higher mortality rate in patients who are given erythropoietin stimulating agents, to correct hemoglobin in excess of 14 grams per DL. However, this study was contradicted by CAPRIT studies that show that there is a slower decline of graft function with erythropoietin control of anemia. It has been speculated that the difference in the CAPRIT studies and CKD trials is the greater inflammatory burden in CKD cohorts, because they tend to be sicker patients. And the larger erythropoietin requirements, therefore higher cardiovascular morbidity in this group. On the other hand, it is possible that the smaller sample size that we have in the CAPRIT studies could account for the limited power to detect adverse cardiovascular outcome in that cohort. So, as previously mentioned, post-transplant anemia is not the same. The etiology varies with chronological phase. So if we try to treat them the same way, it's going to be disappointing. And we'll have a feeling that we're not doing good job. And because of that, we may not be motivated to do anything. So in the first 3 months, the reason for the anemia is usually from ischemic reperfusion injury. There is also blood loss from surgery and phlebotomy. You know how many venipunctures that many of these patients will require immediately after surgery. Also the intensity of the immunosuppression that we're doing, post-steroids and thermoglobulin, and whether the patients experienced delayed graft function or not, or whether there was poor pre-transplant nutritional status. As for post-transplant anemia in the first 3 to 12 months, it is predominantly due to iron deficiency, and sometimes it may be due to immunosuppressive agents and other pharmacological agents such as Bactrim and Varsites that are commonly used for these patients. It may also be due to opportunistic infections, and sometimes it may be due to the fact that it may be more common in females because some females will resume menstrual activity, which will result in a greater degree of anemia compared to men. After 1 year, in addition to immunosuppressive agents and iron deficiency, chronic allograft nephropathy tends to become of increasing significance. So the pathophysiology of highly post-transplant anemia, there tends to be a rise in erythropoietin in the first 3 postoperative days. This is mostly due to renal hypoperfusion, which results from ischemic reperfusion injury. Now, with graft recovery, erythropoietin tends to remain elevated at least in the first 2 weeks. And initially, there will be no reticulocytosis because bone marrow response tends to be impeded, by persistent uremia and inflammatory cytokines that tend to occur usually at that period of transplantation. But there tends to be a biphasic pattern such that there is a second but smaller erythropoietin peak by 20 to 30 days. So I can show that you can see that the first erythropoietin peak is associated with a decline in hemoglobin in the first 2 weeks of transplant as a result of ineffective erythropoiesis. But the second erythropoietin peak is associated with gradual increase in hematocrits that reaches a peak up to about 33% between second and third months of transplant period. Now, iron deficiency is inevitable in early post-transplant period, and there are many reasons why that should be so. We tend to use aggressive erythropoietin during hemodialysis, which results in high iron turnover rates, which invariably is going to result in a low tissue reserve of iron. We also know that there tends to be supranormal release of erythropoietin in response to ischemic reperfusion injury, which is going to mobilize a lot of the iron pool. There is also mandatory oxidative inflammation around this time of the transplant, because which results in hepatic synthesis of hepcidin. And hepcidins, we know, will reduce GI absorption because of a block in ferropoietin. So recovery of anemia in the first month of transplant is invariably associated with progressive decline in serum ferritin. In fact, if you look in one study at least, there is a low serum ferritin invariably increased from about 4 to 22% in the first 3 months of a kidney transplant. So what this brings to mind is that there is need for randomized control trials on the cost-benefit use of the available therapeutic options. While oral iron may be adequate for some people, IV iron may be necessary for some other people, and definitely not all of them is going to be needing erythropoietin, at least for early post-transplant anemia. So in short, one size does not fit all. As for late post-transplant anemia, the prevalence rate is about 20 to 57%, and it's mostly due to impaired graft function. Iron deficiency is also important, and you may also find it in more females than males. Now, one major difference that we know between the kidney transplant recipients and chronic kidney disease is the use of immunosuppressive agents. In fact, the wide variation that we have in the prevalence rates of anemia, may reflect the different immunosuppressive protocol depending on the transplant programs that you are dealing with. We do know that in one study that compared a group that was switched from cyclosporine to sirolimus with another group that was left to continue with the use of the cyclosporine, there is lower hemoglobin in the sirolimus group. We know that sirolimus tends to interfere with GI ion uptake. This is most likely because there is hepatic secretion of hepcidin by sirolimus. It also tends to reduce bone marrow ion utilization. Retrospective renal transplant recipients tend to be more susceptible to ACE inhibitor. And the reason for this is that there is increased expression of angiotensin II type 1 receptors on erythroid cells. We do know that azathioprine, MMF, OKT3, and ATG, they all cause bone marrow toxicity or variable effects on red blood cell line. The goal of anemia therapy should be, we should be optimizing the graft function. We should be improving the quality of life. We also should be preventing blood-borne infections and avoid HLA sensitizations by minimizing blood transfusion. Now, for early post-transplant anemia, there could be two approaches into the way, we deal with it. We could follow the KDIGO guideline on clinical surveillance for early diagnosis of anemia. And when we find new onset anemia, we should investigate them, with iron indices and serum folates. Alternatively, we may do empirical oral iron therapy for all kidney transplant recipients in the first 2 weeks. Majority of them are going to be having iron deficiency. So technically, what are we waiting for? And if there is, and then we continue to perform CBC surveillance as a KDIGO guideline. And if there is anemia, then we do reticulocyte index in about 2 weeks. If the reticulocyte index is greater than 1.5, it substantiates the diagnosis of anemia. If it is less than 1.5, then you have to evaluate for alternative etiology. You should suspect there could be drug-induced post-transplant anemia if there is associated thrombocytopenia and leukopenia. If there is thrombocytopenia and leukopenia, we should also try to eliminate the possibility that there could be viral infection. Now, if there is severe anemia, which I define by hemoglobin less than 9 grams, and there is severe iron depletion, which I define by T-cells less than 20% and ferritin less than 100 grams, it may be appropriate to give IV iron to this group of patients. At least in one study, the routine IV iron was given to a group of patients, to a cohort of patients, and it restored 92% of pre-operative hemoglobin mass, leading to the reduction in the rate of blood transfusion. Many years ago, because of the anaphylaxis that we feared that may come from the use of iron dextran, it may not be justifiable to use this kind of regimen. But nowadays, we do have IV iron therapy, that are very, very safe. We have a lot of iron formulations that may be relatively safe and can allow this kind of treatment protocol. Now, as for the late onset anemia, we could do empirical iron by 1 to 2 years for all kidney transplant recipients, or earlier, if we detect there is already decline in graft function. Now, if then we should perform reticulocyte index, in 2 weeks, okay, to detect, and if the reticulocyte index, is high, then we'll continue with the oral iron therapy. If it is low, we evaluate for alternative etiology. Things to focus on may be folate deficiency, vitamin B12, and viral infection. KDIGO actually recommend that you could give IV iron for this group of patients if this T-sat is less than 30% and serum ferritin is less than 500. Now, the need for erythropoietin for this group of patients is when there is severe anemia defined by less than 10 grams hemoglobin, if there is a rapid decline in hemoglobin, or at the discretion of physician. Now, there is pitfall in this recommendation, in my opinion, because serum erythropoietin is less predicted by GFR loss in kidney transplant recipients compared to non-dialysis CKD. In fact, in my opinion, it may be more cost beneficial to determine serum erythropoietin level in patients who fail to respond to iron therapy and those with transplant CKD stage 3 to 5. Okay, this is the end of the talk, and I do have a poetry for you, which is based on a parody of a child on dialysis, which I equate to a bird that is living in a cave. So I will go through it. The motivations for this kind of poetry comes from the fact that sometimes I try to wear the shoes of our patients, that are on dialysis. So you could imagine what is going on, in the inner mind of a patient that is 7-year-old, that is on dialysis probably for about 2 or 3 years, and that is awaiting kidney transplants. So it says this: I would like to fly as far as the sky. You need to wait for your wing to grow. My wing is grown. I can rise to the cave top. I just need a light to behold my future. What more light, if I may ask? There are 3 windows with a ray of hope, 3 days in a week that is full of promise. As I stretch my neck through the windows, I may catch a glimpse of the sky above. My souls are bigger for my body to behold. I need an escape from a life of misery. Patiently I wait for a visiting caveman. He heals my soul, but the trouble remains. I need a miracle far bigger than my healer. Far away in a town beyond my reach, a tragedy befalls and the man dies, leaving behind a priceless kidney. I finally rejoice, the cave shall open. Hold your breath and wait for me. I'm coming out with a life of glory. So precious it is, it can change your world. Thank you for listening.
Well, thank you for that talk. Our next speaker for the day is Dr. Mariana Markel, who's the Associate Professor of Medicine in the Division of Nephrology at SUNY Downstate, and she'll talk about disorders of mineral metabolism.
So I want to thank Dr. Tedla for inviting me to speak on a topic on which there is absolutely no evidence. So I will do my best with what exists in the literature. Okay, so it's late in the day, so I thought I would start with a case study and ask you what you would do if the computer doesn't fall off here. So Ms. G, this is a true case, is a 47-year-old woman who suffered from an unknown glomerular disease as a child and received her first kidney transplant at 13 years of age. She subsequently has undergone 3 kidney transplants, the most recent of which was 5 years ago. She's had bilateral hip and knee replacements and complains of severe bone pain. Her DEXA reveals osteopenia. Her LH and estradiol suggest she is menopausal. Her 25-hydroxy vitamin D level is less than 10. Her serum calcium is 9, and her serum magnesium and phosphate are normal. Her intact parathyroid hormone is 450 picogram per milliliter. So how will you approach Ms. G's bone disease? I'd like to see a show of hands, and you can choose more than one. How many of you would start a bisphosphonate on this woman? How many of you don't know what a bisphosphonate is? No, I'm kidding. How many of you would do a parathyroidectomy? I'm looking at the surgeon here. How many of you would start 50,000 units of vitamin D ergocalciferol? Okay, how many of you would give her cinacalcet or Sensipar? And how many of you would start her on hormone replacement therapy? Okay, you're going to have to wait to the end of the talk to find out what happened to her. That's just the teaser. More at 11. But anyway, okay, so the minerals I'm going to talk to you about today are calcium, phosphorus, and magnesium. In the early post-transplant period, patients may actually be I got to do 2 things at one time. It's like chewing gum and walking. So in the early post-transplant period, patients may be either hyper, hypo, or normal calcemic. They may also be hyper, hypo, or normophosphatemic. And the factors that may actually influence their calcium and phosphorus include their parathyroid status pre-transplant, as well as FGF23 levels. There are no data on diuretics, but theoretically, since several of the diuretics, as you know, hydrochlorothiazide decreases urine calcium excretion, whereas furosemide increases it. there are no data on the impact on the transplant. Then there are dietary habits, and that's something that we are very interested in, and I'll show you some data, particularly as regards to phosphorus. And finally, of course, there is the issue of kidney function. Obviously, in the patient with a poorly functioning kidney, immediately post-transplant, they're going to have a tendency toward hyperphosphatemia and all the same mineral disorders that you would see in a patient with CKD. So in one study that looked at what happens to parathyroid status post-transplant, 865 patients were followed. 63% had an elevated parathyroid hormone at transplant, and there was a gradual decline toward normal over 3 months. 17% of them, however, had a persistent hyperparathyroidism, and 52.7% were hypercalcemic at 1 year post-transplant. 13% remained hypophosphatemic at 5 years post-transplant. And we are very interested in that area, and my hypothesis is that this was not due to their parathyroid hormone issues, but I'll talk about that in a couple of minutes. Patients who actually remained hyperparathyroid, the only factor that they found to predict this was that they had been on dialysis longer than those longer pre-transplant than those who recovered their parathyroid function. So this is just showing you the slide that over time there is a persistence of hyperparathyroidism. A certain number of patients received parathyroidectomies, and then a fair number of patients maintain hypercalcemia. And I think that's our experience here as well, is that a certain number of patients, a fair number of them, remain hypercalcemic years after the transplant. So what about FGF23? Just to remind everybody about FGF23, the driver for FGF23 is thought to be hyperphosphatemia. FGF23 is produced by the bone, and the bone puts out the FGF23 into the serum, and so the serum FGF23 then rises, and that results in a decrease in phosphate reabsorption by the kidney and hyperphosphuria, and therefore you then get hypophosphatemia. And many of the thoughts about the early post-transplant hypophosphatemia that occurs is that it's due to a persistent of elevated FGF23, and we see often very elevated FGF23 levels in patients who are on dialysis. Oops, I keep forgetting to do this one. So what happens to FGF23 post-transplant? That is not very well known. In one study that I was able to find that looked at only 27 patients, 85% of these patients did develop hypophosphatemia, defined as a phosphate value of less than 2.5. FGF23 was associated with phosphate values as well as 125 vitamin D, and it suppresses 125 synthesis, as well as urinary phosphate. But PTH, interestingly, was not associated with the phosphate value. So it looked like phosphorus was driven more by FGF23 in the early post-transplant period in this population. What was interesting is that they said that FGF23 values fell by 2 months post-transplant. Now, I have the data here, and it's kind of all over the place as far as I can see. I mean, I guess you could say they fell, but certainly some patients remained stable and some went up. So anyway, their conclusion was that FGF23 may not be the determining factor in long-term hypophosphatemia, which is something that I actually agree with. So what could be driving late hypophosphatemia? Well, a study that was done by Sylvia Wu, who's hiding back there somewhere, as a medical student with us, we looked at 14 long-term patients with excellent kidney function. Their creatinine was on average 1.5 milligram per deciliter. They did 24-hour diet recall, and their mean phosphorus was 2.97, but 57% of them had a phosphate value less than 2.5, which would meet the criteria for hypophosphatemia. And this is even late, more than 5 years post-transplant. What was interesting, and we thought this was all from FGF23, was that in fact their fractional excretion of phosphate, which would be an indicator of phosphaturia, was very, very low, and so was their random urine phosphorus, which suggested they were actually hanging on to all the phosphorus they possibly could. And what we found was that their daily phosphate intake was only slightly above the RDA, or the recommended daily allowance for phosphorus. And when we actually asked patients, how were they making their food choices, many of them were maintaining a dialysis diet. And during the dialysis period, of course, we tell patients not to eat any phosphate-containing products. And so it's as if they had lost phosphorus early post-transplant, probably due to elevated FGF23 levels. They were total body phosphate depleted, and they just weren't able to replace their phosphate because they were continuing to follow a relatively restricted phosphate diet. To go along with this, patients with the lowest caloric intake also had the lowest BMI and the lowest protein intake as well. So it looked like clearly their dietary intake was a driver of their late post-transplant phosphorus. What's interesting is very, very little data exists in terms of what transplant patients eat and its impact not only on things like phosphate and calcium, but I was thinking about anemia and some of the other issues that occur in the late post-transplant period. So moving on to magnesium, hypomagnesemia is extremely common. Any of you who take care of transplant patients, I'm sure, know that the majority of your patients are hypomagnesiemic. It's seen in association with calcineurin inhibitor use. It's tacrolimus much more than cyclosporin, and it's thought to be due to downregulation of something called the transient receptor potential melastatin 6, or TRMP6. TRMP6 is also affected by epidermal growth factor expression. And sorry, guys. And I have the right thing? Yeah, I do. So, so TRMP6 is actually affected in itself by epidermal growth factor, and both of these are affected by the calcineurin inhibitors. What happens then, TRMP6 is very important as a driver for magnesium reabsorption in the loop of Henle. And so if TRMP6 is low, then you're going to waste magnesium. And that's something that's been seen with patients who are treated with calcineurin inhibitors. There are also other factors. We all know that diarrhea can occur due to mycophenolate or other causes post-transplant. And then there's the question of diuretic or proton pump inhibitor use. It's known in the general population that proton pump inhibitors are associated with hypomagnesemia. But the question is this something, because we give a lot of our patients PPIs, is this affecting their serum magnesium as well? I will tell you there are no data on diuretics and hypomagnesemia in the transplant patient, but there are data on PPI use, which I'll show you in a minute. And finally, there are no data on dietary habits, but clearly it is hard to eat enough magnesium to replace magnesium once you become hypomagnesemic. Very few foods are high in magnesium other than things like Brazil nuts and asparagus, which is not high on our diets, and the nutritionists are laughing back there. They're not really highly eaten foods among our population for sure. So, and then hypermagnesemia is very rare. I'm not even going to talk about it unless the patient has a failing kidney and is taking some sort of magnesium-containing antacid. So in terms of calcineurin inhibitors, 41 tacrolimus-treated patients were compared to healthy controls, and they showed that 43% of them were hypomagnesemic. And when they looked at their fractional excretion of magnesium, again, this is a measurement of how much magnesium is being wasted in the urine, so to speak, it was much, much higher, significantly higher than a normal control. Again, it was an extremely poorly done study. The diets weren't controlled. But clearly the patients were spilling much more magnesium, and it looks like it's a urinary loss situation. And it correlated with tacrolimus level as well as estimated GFR. So patients, ironically, who have not ironically, but who have good kidney function are the ones you're going to see who become hypomagnesemic, not your patients who have, late stage chronic allograft nephropathy or something like that. So interestingly, there is a study looking at the interaction between the CNIs and the proton pump inhibitors. And the reason the PPIs may affect magnesium is the same reason as the CNIs. In fact, they also affect transient receptor melanostatin P6 expression. And so they looked at 512 patients with excellent kidney function, creatinine of 1.5. 20% of them were taking PPIs, but by multivariate analysis, there was actually no interaction of PPI use and magnesium. The independent predictors, again, was CNI use, whether it was tacrolimus versus cyclosporin versus sirolimus, which has a much less of an effect. The absence of mycophenolate mofetil, which was probably related to a higher dose of their CNI, and then again, patients who had better kidney function were more likely to have the lower magnesium level. So why do we care? What are the clinical consequences of these disorders? Believe it or not, high calcium and phosphorus increase the risk of post-transplant mortality. Both hypercalcemia and hyperphosphatemia have been associated with an increased risk of patient death in a 228-patient study with an 8-year follow-up. All-cause mortality was increased. There was a hazard ratio of 1.21, which was significant for increase in phosphorus or an increase this for hyperphosphatemia or hypercalcemia. But as far as graft loss was concerned, only death uncensored graft loss was significant. The effect on death-censored graft loss was not seen. So it looked like the biggest issue here was that there's an increased risk of mortality. Again, it doesn't speak to what the causality here is, but it's a signal that's worrisome that we shouldn't just ignore these issues. The other issue is that hyperparathyroidism also causes an increased risk of mortality, and that may have blurred the pictures of that previous study. This is an even bigger study of 1,800 patients that were followed from 5 years post-transplant to as many as 11 to 12 years. And in multivariate analysis, PTH was significantly associated with all-cause mortality, with a 4% increased risk for every 10-unit increase in PTH, as well as, in this case, an increased risk for graft loss. And in general, a lot of times I find we either don't measure PTH or we kind of ignore it in our transplant patients, or we say there's nothing we can do. And I'm going to talk to you later about what the KDIGO recommendations are. They're not also very exciting, but we have something. The PTH level, interestingly, was not associated with major cardiovascular events, although it was associated with mortality. And parathyroid hormone above the upper limit of normal indicated a 46% higher risk of death and an 85% risk of graft loss. So it looked like it was something other than major cardiovascular events that were driving mortality, but the authors did not comment on what specifically that was. Magnesium is even more concerning as far as I'm concerned, especially because it's something that we also tend to overlook. Magnesium affects the parathyroid gland. There may be effects on macrophage function, which I won't speak to because none of them have been demonstrated in the transplant population, but tuck that away in the back of your minds. Clearly, there are some effects on vascular calcification, although there's no data in transplant. I'll show you in the general population. The interesting thing to me is there are data accumulating that there's an increased risk for new onset diabetes, and then bone disease I'm going to talk about at the last half of my talk because, of course, it's a very important issue. Graft loss, it's really unclear because as you lose grafts, your magnesium tends to go up as your kidney function deteriorates, so there's a lot of confounding in the studies that have been done. So in magnesium and graft loss, 60 cyclosporin treated patients were studied. They were grouped into a low magnesium and a normal magnesium group. The outcome variable here was graft loss and rate of progression of kidney disease. And graft loss was reported as greater, but as I'll show you in the next slide, the relative risk was not significant. And the other thing to remember about when you're looking at studies of magnesium is that magnesium is intracellular. And so serum magnesium is a very poor measurement of total body magnesium. And so sometimes it's very difficult to, when you have such a small difference in groups, to know exactly what they're studying. So here you can see the actual data. I don't have a pointer, but if you look at B, it looks very nice and they say that it's significant, but the relative risk crosses 1. So somehow they slid this into the literature to suggest that somehow kidney allograft survival was associated with magnesium, but unfortunately the data are very poor, and then N by the follow-up last N is like 2 patients. So again, be careful of these studies. They're very poor quality. So what about diabetes risk? There are better studies in terms of the risk of diabetes. There's no question in animal models and diabetic rats that low magnesium intake decreases tyrosine kinase activity of the insulin receptor in muscle. In type 2 diabetics, and this is not CKD patients, magnesium supplementation increases insulin sensitivity and improves glycemic control, and there's many studies to this effect. Multiple population studies suggest an association between diabetes and low magnesium intake. In the largest study that I could find, which was published in JASN, 948 patients were published in retrospective review. The hazard ratio for new onset diabetes after transplant was 1.24 per 0.1 millimole per liter decrease in magnesium, and this was a significant finding. Hypomagnesemia with a serum magnesium less than 1.8 was also significantly associated with an increased risk of new onset diabetes, with a baseline hazard ratio of 1.58, which is pretty impressive. And then they did a couple of other fancy schmancy tests to show that it's even worse if you look at time varying, if you follow the magnesium over time. But I think the point is made that in all of the ways that they analyze this, if you look at the risk for new onset diabetes, the hypomagnesemic patients are on top and the normomagnesemic patients are on the bottom, and clearly the risk is increased for patients who are persistently hypomagnesemic. So I do not, if you take away one thing from this talk, I hope it's that please don't ignore magnesium in your patients, because you may be increasing their risk for new onset diabetes. Finally, magnesium and atherosclerosis. There's no studies in transplant patients, but there was a study in the genetics of atherosclerotic disease in 1,200 Mexican patients, and they found that serum magnesium was inversely associated with coronary artery vascular calcification score. And this is a study that was grouped into quartiles based on magnesium ratio, and the odds ratio was for the highest quartile versus the lowest was significant, and I'll show you that in the next slide. Just at the bottom here, I'm showing you that basically they controlled for every possible thing under the sun, so these are pretty impressive data. So here you can see the two significant findings were for the risk of hypertension, and I'm not talking about that today, but clearly in other populations, low magnesium also increases your risk for hypertension. And the CAC score, which may or may not be relevant to our patients, was elevated in patients who are in the lowest quartile for magnesium. And that's not severely hypomagnesemic, but it's concerning when you heard earlier today that the atherosclerotic disease that seems to occur in our patients with transplant doesn't necessarily behave in the same way as the atherosclerosis in the, quote, general population. So what about the parathyroid gland? Severe hypomagnesemia suppresses parathyroid response to hypocalcemia in a mechanism that's unknown. It also causes resistance to parathyroid hormone by bone. It interferes with G protein activation in response to parathyroid hormone, and it decreases generation of adenylate cyclase, or maybe, that's the theory. So, you know, hypomagnesemia may also, if you have a patient who is severely hypoparathyroid, you clearly need to look at their magnesium level. Magnesium replacement in severely hypomagnesemic patients with inappropriately low PTH and hypocalcemia can actually normalize levels. And again, this is not in CKD patients. This is in the normal population, but it is unlikely to be different in our CKD patients. So for the last half of the talk, I want to concentrate on bone disease, because obviously that is a significant problem in our population, and it's clearly linked to mineral disturbances. So renal osteodystrophy, osteoporosis, bone fracture, and osteonecrosis all occur in transplant patients. The estimate is a bone loss of 0.1 to 5.7% in the lumbar spine in the first year post-transplant. The earlier reports of 4 to 10% were based on high-dose high steroid immunosuppression, so it's probably much less than it was in the early literature. After the first year, the good news is that bone density seems to remain stable, but below healthy age-matched controls. The bad news is that 22.5% of kidney transplant recipients do experience a fracture, which is approximately 4 times the general population. PTH at over 130 at 3 months is an independent risk factor for fracture, with a 7.5 increase in fracture risk. And interestingly, hypophosphatemia has been associated with severe alterations in bone turnover, including decreased osteoblast activity and defective mineralization, which may contribute to fracture rate. And then low vitamin D, which is not a mineral, so I'm not talking about my favorite subject today. But I have to mention vitamin D because it's seen in over 30% of post-transplant patients. In our patient population, I think it's seen in over 90%. But hypocalcemia and defective mineralization are also seen in patients who have low vitamin D, so that shouldn't be ignored as well. When they looked at risk factors for fracture in kidney transplant recipients, and this is a 507 patient study, unfortunately going over an extremely long period of time during which immunosuppression type changed dramatically, 1976 to 2011. The mean age, 54 years with 45% women. Mean time pre-transplant was 63 plus or minus 43.6 months, excuse me. 12% suffered 89 non-vertebral fractures, 44 of them one fracture, 15 2, and 5 3. But what I want you to notice here is that 28% of the fractures were in the hands and feet. And I think that's been my experience, and I'd be interested to hear from the other transplanters in the audience. But my experience is that our patients tend to fracture their hands and feet. And the reason that that's important is because it's not something you can predict by DEXA. Now, all the patients with fractures had a lower bone mineral density of the femoral neck in the period of 1 to 10 years post-transplant, and they were more likely to have osteopenia and osteoporosis, which is not particularly surprising. They also had a higher serum alkaline phosphatase in the first year. They were older, and they had a lower serum albumin. The frequency of treatment with a bisphosphonate, calcium, or phosphate did not differ between the groups with or without fracture. But what I found interesting was that, in fact, and then 47% occurred between 3 and 10 years post-transplant. But vitamin D supplement, which was mostly given in the active form, was actually prescribed more frequently in the group without fractures, and the fracture-free interval was longer, but it was not statistically significant. But this was kind of an interesting observation, again, hearkening back to the importance of measuring vitamin D as well as magnesium and phosphorus. So finally, I want to talk to you about the KDIGO recommendations that came out about a month or so ago. Now, mind you, almost all of these recommendations are fairly poor level, based on fairly poor evidence, unfortunately. But this is the expert recommendations. The recommendation is a weekly measurement of calcium and phosphorus. Oops, sorry about that. A weekly measurement of calcium and phosphorus until stable, whatever that means, an intact PTH once, quote, depending on the presence and magnitude of abnormalities. In other words, you can kind of do what you want. For stage 3B, a GFR of greater than 30, they suggest measuring calcium and phosphorus every 6 months and a PTH every 6 to 12 months. For stage 4 or higher, GFR less than 30, to measure calcium and phosphorus every 1 to 3 months and PTH every 3 to 6 months. And they do suggest something that we don't necessarily do, which is to measure alkaline phosphatase yearly, unless the patient has an elevated PTH, and then they suggest you measure it more frequently. They then say that calcidiol, or 25-hydroxyvitamin D levels, might, and this is their words, be measured with testing intervals determined by value and intervention. I certainly measure them in my patients. I'm not sure why they hedge their bets so much, but I guess there's just no data. In patients with risk factors for osteoporosis, bone mineral density testing is suggested to assess fracture risk if the results will alter therapy. So if you're not going to change what you're going to do based on your bone mineral density study, don't order it. There are no prospective studies evaluating the ability of DEXA to predict fracture in kidney transplant recipients. The recommendation is based on one retrospective cohort study that was published in 2008 that suggested an association of T-scores and fracture risk. But I always get patients coming back to me from their gynecologist saying he wants to start a bisphosphonate because I have a terrible bone density. So again, be aware that the data don't support that. The study didn't look at multivariate analysis or control for any factors other than gender, diabetes, and age. So what do they suggest for therapies? For patients with a GFR over 30, the following may be considered: vitamin D type not specified. That's, do you give them cholecalciferol? Do you give them calcitriol? It doesn't say. Calcitriol, alpha-calcidol. Anti-resorptive agents, they say, might be considered, and that's the bisphosphonates. Treatment of choice should be guided by abnormal calcium phosphate, alkaline phosphatase, PTH, and vitamin D levels. That doesn't help us too much. It's reasonable to consider a bone biopsy to guide treatment, but this is an ungraded recommendation. And believe it or not, there are no data to guide therapy after the first 12 months post-transplant. So after 1 year, you're kind of on your own. So the other thing I want to point out to you is that cinacalcet is not approved for patients with kidney transplants, although we do use it. And it's failed to show improvements in bone mineralization in the studies that were done. The other thing is denosumab, the anti-rank ligand, was used in one study, and but it made it into the KDIGO recommendations as may be effective in new transplant recipients. In fact, the study, which had 80 patients in it, showed a slight increase in bone, but significant increase in bone density in the denosumab-treated group, but they didn't look long-term. And you should know that long-term denosumab has been associated with abnormal fractures, osteonecrosis of the jaw, and this is in the normal population. So I would be very, very careful about using something like denosumab in our transplant patients in whom we don't even understand exactly what's going on with their bones. KDIGO believes that steroid minimization protocols will lessen the urgency for correcting bone mineralization in our post-kidney transplant recipients, and that's their happy send-off to their recommendations here. So what are the take-home points here? Obviously, mineral disorders are common: hypercalcemia, hypophosphatemia, and hypomagnesemia, and in the failing allograft, hypocalcemia, hyperphosphatemia, and hypermagnesemia. Mineral replacement, I think, is very important to avoid long-term consequences, including bone disease, metabolic disorders, and possibly even mortality. And at this time, I can't see any reason not to supplement magnesium in patients who are hypomagnesemic. Early data suggest, and we can talk later about, what type of magnesium. I don't really have time now, but there is some evidence that magnesium chelates like acetate and lactate are better absorbed than oxide. Early data suggest a possible positive effect of vitamin D supplementation on bone fracture risk. DEXA may not be useful in predicting patients at risk for fracture, as many patients fracture their hands and their feet, not their long bones. And bisphosphonates should be used with caution, especially in patients with long-standing CKD who may have adynamic or low turnover bone disease, in whom you can turn off, oh, I'm sorry. Oh, shoot. Why isn't it going? It's not going. It's stuck. It's not going. Oh, I think maybe I got it now. I got it. Okay. Okay. So bisphosphonates should not be used. It should be used with caution, because patients who have adynamic or low turnover bone disease, you can have a really, you can shut their bones off entirely and end up with a really big disaster. The bisphosphonates, as you know, stay in the bones for years. So what's the best approach to mineral disorders? Replace what type of magnesium? There's the whole issue of whether calcium supplementation increases cardiac risk. Should you do a parathyroidectomy? What's the best way to screen for post-transplant bone disease? Should you do a DEXA? Should you do bone turnover markers? I think basically we have a lot more questions here than answers. And it's about to start beeping at me, but I want to tell you what happened to that patient, if you guys can bear with me through the beeps. So just to remind you about Mrs. G, she had all sorts of things going on, but basically she had severe bone pain, and that's what drove us looking for some sort of a treatment for her. So I gave her 50,000 units of ergocalciferol, as most of you thought was a good idea, and was recommended at the time by Kay Doki, and her calcium immediately went to 14 milligrams per deciliter, and we admitted her. She was then given fluids. She responded to fluids. She refused a parathyroidectomy at that time, and her calcium eventually normalized, but she was still in severe pain. So what I did, once the beeping goes away, what I did was I started her on 0.5 micrograms of doxorcalciferol and 400 units of cholecalciferol a week. And believe it or not, within 6 months, her bone pain resolved, her PTH started falling, but then all of a sudden, it's as if her bones woke up and her phosphate fell. It looked like she almost had a hungry bones syndrome. So she went to have to eat foods with phosphorus in them, which was very interesting. And that went on for about 6 months, and then that normalized too. And now she's about 5 or 6 years later. She's on 400 units of vitamin D and half should be a microgram of doxorcalciferol daily. Her PTH fell to 123. She has a normal phosphate and a calcium that runs about 10.8, and her pain completely resolved, and she feels great. But a month ago, she fractured her foot. So I will leave you with that.
Thank you, Dr. Markel. For the last talk of the day is our next speaker, Dr. Rainer Grusner, who's the chairman of the Department of Surgery, and he'll talk about optimizing kidney transplant outcomes in diabetics through simultaneous or subsequent pancreas transplant.
Okay, good afternoon. So I understand I'm the last obstacle. It is actually a new experience for me. I must say I've never given a last talk on a Friday the 13th. So I'm not sure if this prognostically is good or bad. We'll find out, but whatever it is. So I do have a number of slides, and you should just lean back, relax. While I'm talking about something that we want to bring back to Downstate. It has been done in the 1990s, but then it kind of evaporated, despite the fact that Brooklyn is considered the capital of dialysis and the capital of diabetes in the country. But both islet and pancreas transplantation are not offered at our institution. So I'll start with a few remarks on diabetes in general to set the stage for pancreas transplantation, then why we do pancreas transplantation, and how a pancreas transplant impacts graft function, both kidney graft as well as native graft function. Now, I try to multitask, but I do have now two of these things in my hand, so we'll have to see how all this works. Okay, and I think I'll do it like that. So the first few minutes is on what you already know. Diabetes has become a huge, huge problem for us, not only in the United States, but in the Western world. It's estimated that about 750 million people are diabetic in the world. In the US, about 30 million patients are diabetic, but more importantly, 86 million, just think of that, 1/3 of the population is pre-diabetic. Out of those, only a fraction, about 2 million, are type 1 diabetics. You all know that diabetes is the leading cause of end-stage renal disease, blindness, and amputation. It's probably grossly underreported when it comes to the cause of death. But look at that. This makes, the wars in Iran and Afghanistan on an annual basis appear almost small compared to what we spend on the treatment of diabetes. This is something that I shouldn't show to nephrologists because you all know that. I just looked at the incidence of end-stage renal disease in diabetics, and I chose whites. I could have chosen African Americans, Native Americans, Indians, Asians, everyone. This is how it looks now, and this is only 10 years later. So we are looking at a major, major health problem in years to come. Now, I just heard today that the Affordable Care Act is going to be reformed. Let me just tell you that for these patients, this is not going to be an improvement. Now, what does diabetes do? We all know that it diminishes quality of life, but more importantly, and those are data from the UK, life expectancy of patients with type 1 diabetes is reduced by about 20 years, for type 2 diabetes, 10 years. The Pittsburgh study, which has about 30,000 people in the registry, shows that patients born with type 1 diabetes after 1965, and obviously benefiting from the progress that we have made in the 1980s and 1990s, have a life expectancy of about 10 years less than the normal population. So how do we treat diabetes? Well, first there is intense insulin therapy, and you all know with the DCCT trial we have made tremendous progress. There is the artificial bionic pancreas everyone talks about. The bottom line is it still doesn't work to the point that we reliably can use it for all our patients. Then there's beta cell therapy, pancreas transplantation more so than islet transplantation, and you all hear every year or so another great result with islet transplantation. Let me tell you, it's not there for prime time yet, and the results are trailing those of pancreas transplantation. And then there's tissue engineering and regeneration, which has become a major, major field in research, and I hope within the next 10, 15 years we will really see some progress there. Now, what are the current problems with insulin therapy? And many of you are familiar with that. Now, first of all, we know that intense insulin therapy is better than conventional insulin therapy. However, and this is important, and that's something you have to remember, the increase of hypoglycemic episodes is real. And what it does is it comes along with a mortality of 2 to 8% per year. Now extrapolate that on the life expectancy of a diabetic, 30, 40 years. You multiply that with 2% or with 6%, and you know, some of these patients will die from hypoglycemia. And there are actually pathology reports out on patients where a cause of death could not be determined except that they were diabetic. And the presumption was that, many of these patients died from hypoglycemic episodes. More importantly, no matter how well you do with intense diabetes therapy or with a biogenic pancreas, the development and the progression of secondary diabetic complication continues. So near normal glycemia is not good enough to prevent the progression and the development of secondary complications. Now, this is a person who performed the first pancreas transplant, Richard Lillehei. He would have gone into history as one of the great American surgeons, so maybe one of the greatest in the 20th century if his life hadn't been cut short. He was training for the Boston Marathon, fell on a beach in Florida, broke his neck, and that was just a few years after he performed the first pancreas transplant. He also did the first intestinal transplant in the world. So a true pioneer. This is the way, the first transplants were done, and I won't bore you with the technical aspects. But why do we pancreas transplants? Now, first of all, and that's a no-brainer, and actually the nephrologists have always been the friends of transplant surgeons. I don't have to say that many times, but nephrologists are the one that send us patients for combined pancreas and kidney transplant because these patients with end-stage renal disease need a kidney transplant, and by virtue of the kidney transplant, they already get immunosuppression. So the only additional risk is the surgical risk of adding a pancreas transplant to the kidney transplant that these patients are already getting. And we are not killing patients anymore with the procedure, and I will show you that in a little while. We also do pancreas transplants in patients without end-stage renal disease, patients that are brittle diabetics, and that's only about less than 1% of all type 1 diabetics. Those are patients, as I said, with hypoglycemic episodes, hypoglycemic unawareness. And then obviously evidence of at least one of these types of diabetic complication that you're all familiar with. Now, we do pancreas transplants in 3 categories. The first one, and most common, as I mentioned already, is based on patients that have developed end-stage renal disease and that need combined pancreas and kidney transplants, simultaneous pancreas and kidney transplants. Then there are the post-uremic patients that had undergone a successful kidney transplant, remain diabetic, and their diabetes gets worse because of the immunosuppression, primarily the side effects of calcineurin inhibitors. And then the smallest group are the pancreas transplant alone patients that are non-uremic and diabetic patients, the truly brittle diabetic patients. Now, I should mention that a lot of the slides that you will be seeing now are the results of the International Pancreas Transplant Registry that my wife directs. And it is only one, the remaining one of all organ transplant registries in the world that not only has the data of the United States, but the rest of the world in it. So it's a truly international registry. But, and some of these data were shown before, why do we transplant in general? Now, these are patients that are on the wait list for a kidney transplant alone or a combined pancreas kidney transplant. So those are patients that are considered, in better health than patients that just undergo a kidney transplant. But what you can see is that at 10 years, only 20% of these patients are still alive. So if patients stay on the waiting list for 10 years, 80% will die awaiting a kidney transplant or a combined pancreas and kidney transplant. Now, patients that have undergone a kidney transplant in the past and then are waiting for a pancreas transplant subsequently, at 10 years, if they stay that long on the waiting list, the mortality is about 50%. But even for pancreas transplant alone patients that are only brittle diabetic patients that otherwise are fine and have been cleared for a transplant, the mortality at 10 years is about 25%. So we lose patients and patients and patients while waiting on the waiting list. Now, what is the post-transplant survival of patients? And frequently it has been said pancreas transplants are harmful to kidney transplant recipients. And I think it's very impressive if you look at the data here. So at 10 years, the one line that falls out are deceased donor kidney transplant patients. They do the worst. So diabetic uremic patients that receive a deceased donor kidney transplant at 10 years, only about 45% of them are still alive. Then you look at living donor kidney transplant patients and take a look at that. This is, a gray beige line or so. Pretty good. At 10 years, about 75%, or in this case, 65% of the patients are still alive. Then you look at patients that undergo combined pancreas and kidney transplant. The number is even better. It's 71%. And then you look at patients that undergo a pancreas after kidney in blue. Those are patients that had a previous kidney transplant and then undergo a pancreas transplant. Now, if you look at the results from the time of the kidney transplant, that could have been 1 to 10 years before they received the pancreas transplant, the results are almost as good as they are for living donor kidney transplant. However, if you measure it from the time when the patient underwent the pancreas transplant, the survival is even better. It's 75%. So in fact, if you look after a pancreas transplant, the survival, the pancreas after kidney group seems to have the best survival of all the different groups, and I'll talk about that in a few minutes. Now, let me just show you what we have in terms of the International Pancreas Transplant Registry. In the United States alone, we have a cohort of about 31,000 patients. And we also follow, and my wife has been done that now for many years, another 25,000 outside of the United States. Interestingly, in the United States, the number of pancreas transplants peaked in about 2005 and then declined only now to slowly come back, and the numbers for 2017 will probably be higher than the numbers in 2016. So I mean, it's trending upwards again. Whereas in the rest of the world, we continue to see an increase in the number of pancreas transplants. Now, how do we do? I mean, there are certain states in the country that do much better than others. Certain states like Wisconsin, Michigan, DC here obviously is almost an outlier. But if you look at Wisconsin, Minnesota, where the techniques for pancreas transplantation originated from, about 7 to 8 transplants per million population are done. But look here at New York. We are basically at the end of this scale, and we are not doing great. I mean, about 2 patients per million population in a state that has a much higher incidence of diabetes type 1 and type 2 than many of the other states. I mentioned before the numbers have gone down, primarily in one category, the pancreas after kidney transplant, and those are the patients and the category that I will really focus on in a little while. Now, what is the patient survival after pancreas transplantation? Initially, there was concern that we killed patients, and that is true. And the endocrinologists still remember that very well. That's one of the reasons why we don't get that many referrals for pancreas transplant alone. Look, in the early 1980s, in the infancy of pancreas transplantation, about 30% or even more than that of our patients died within the first year. So imagine that doing a transplant these days with a mortality of 30%, you would be crucified. Even for multivisceral or for liver transplantation, you cannot see a mortality that's any worse than that. But look what has happened over time. You know, I mean, the 1970s introduction with cyclosporin, then the introduction of tacrolimus, MMF, and so forth. And look now, I mean, the mortality is anywhere between 1% and 5% at 1 year. Now compare that to a group of diabetic patients, and you will see how much progress has been made, because any cohort, any diabetic cohort, will have a higher mortality than 1% and 5% than the pancreas transplant recipients, as shown here. Now look at 5 years, the same development. Initially, as I said, we lost these patients, but then at 5 years now, we are close to 90% survival. And this is for type 1 diabetics, obviously patients with huge comorbidities. Now this is a very, very important slide, because it shows how important it is that you fight for every single graft. So if a pancreas fails, this is the risk factor for patient death. If a pancreas fails, that risk of death for the patient who received a pancreas and a kidney transplant is increased by a factor of 3. So his or her risk is 3 times higher than that of a patient who still enjoys a functioning pancreas transplant as part of the SPK procedure. If the pancreas fails in a PAK recipient, the risk of death compared to a functioning pancreas transplant is increased by a factor of almost 5. In a pancreas transplant alone patient without a kidney, the pancreas fails, the risk of death is increased by a factor of over 6 compared to a patient with a functioning pancreas transplant. If you thought these numbers are bad, look at what the kidney does. If the kidney fails, your risk of dying, SPK patient, you still have a functioning pancreas in place, is 18 times higher than for someone whose kidney is still functioning. In the PAK category, it's a factor of 3. What all of that shows is that once a graft fails, morbidity just goes through the roof, and we have to do everything to avoid rejection from occurring. Now, optimizing kidney graft function in the SPK category. Now, this is a slide that shows the improvement that we have made over the different time eras. So this is the earliest 20 years from 1966 to 1987, and look how dismal the results were. And this is years post-transplant. So, I mean, at 15 years, about 15 to 18% of the patients of the grafts were still functioning. Now, just see how much progress we have made. But the reason why I want to show this slide is the following. Most of the graft losses for pancreas transplants occur within the first year. So this is including the first year. This is conditional pancreas graft function excluding the first year. So if we exclude the first year where most of the graft losses occur, look, I mean, we continue to make great progress. And 50% of the grafts are functioning, 50%, imagine, are still functioning probably, if we extrapolate it for the most current time period, are probably still functioning at 18 or 19 years. So the half-life of a pancreas in the SPK category that we are looking now, and patients that were transplanted last year, is about 18 to 19 years. And this is almost unimaginable if you think at what happened at the very beginning. Now look at the kidney graft function. Very interesting as well. First of all, slightly better, particularly within the first year. And if you look at the conditional survival, the slope, the decrease, is not as steep as it was on the pancreas. Look at this over here. This is about 8% losses from technical failure. This is only 1 or 2% of graft losses. So the kidney is much safer to transplant in terms of technical complications. We do lose many fewer kidneys within the first year from technical complications than we still lose pancreata. But again, look at the progress that we have been made. And again, if you extrapolate that, the 50% graft function for SPK recipients, half-life, 50% still functioning, is about 17, 18, or 19 years in years to come. No difference when we between kidney and graft outcomes. Sometimes we have heard, particularly initially, that the pancreas is more immunogenic than the kidney. Doesn't appear to be true when we look at the conditional outcome. After the first year, there is no difference in SPK pancreas and SPK kidney graft outcome. Now, this is what I already showed. If one of the grafts is lost, the patient pays with his life. So if both are functioning, three-year patient survival, almost 97%. If the pancreas function and the kidney, if the pancreas fails here, but the kidney is functioning, we go down to about 90%, so about a 7-8% decrease. If, however, the kidney fails and the pancreas is functioning, we go down another 5%. If both pancreas and kidney lose function, we are down to 79%, so almost 20% higher mortality than when both grafts are still functioning. Now, let me talk now about the second category, the pancreas after kidney transplants. This shows you the time interval between the kidney transplant and the pancreas transplant. As you can see, and this is over time from 2000 to 2016, there's an interesting trend here. First of all, with deceased donors in green, we see that the time interval decreases. So patients that had a deceased kidney donor receive a pancreas transplant now earlier than they received in 2000. But the trend is opposite for living donor kidney transplant. And that is in part because some of these patients fall through the grid. We don't remember that our diabetic patients had and have a functioning kidney, and now they actually should get a pancreas transplant because, I mean, they're doing reasonably well. But I'll show you in a minute why we really have to continue to get these patients transplanted. This shows you, like in the SPK category for the PAK's outcome, and as you can see over the different time eras, I mean, huge improvements. Here's again the conditional graft survival, as you can see, huge improvement there as well. Now, my wife did a study in PAK's with one of her postgraduate students, Jean-Paul Kleinkloss. And the aim of this study was to determine if a pancreas after a previous kidney transplant is associated with a long-term decline in renal graft function when compared with a kidney transplant alone. So these are data based on, I spent about a quarter of a century in Minnesota, at our Minnesota data. So my wife took the 303 primary living donor kidney transplants in diabetic patients that were performed between 1995 and 2003. And there are three categories of patients. The first one were 55 living donor kidney transplant recipients that were too sick to receive an additional pancreas transplant. So you exclude the patients that are so sick, they would not withstand a major procedure. Then there is your second control, the Y control. 73 patients were eligible by ADA criteria for a pancreas transplant, but they declined either for personal reasons or they didn't have insurance coverage. As you know, PAKs have only been covered by CMS for the last 10 years. And then there are 104 patients with a pancreas transplant being performed between 2 months and 1 year after the kidney transplant. And the patients outside of that time frame were excluded. Now, these are the data of the initial cohort. No major differences except for the fact that obviously the recipient age in the KTA group was a little bit higher, which would make it maybe more challenging. On the other hand, the percentage of type 1 diabetics versus type 2 much higher in the PAK category. So these are the results, and they were updated just recently. So now we have data going out 15, 20 years because, as I mentioned, the data go back to, I remember correctly, 1995. So we have basically data for now 20 years. So this is what it shows. These are the patients that were too sick to receive a pancreas transplant. If you look at 15 years, only about 10% are still alive. So those are the recipients of living donor kidneys. These are the patients that were eligible, but they were not transplanted for personal or financial reasons. And as you can see, and this is in purple, and then in this bluish color are the ones that underwent a pancreas transplant because they qualified for it. Now, these lines initially cross, so early on we did not see a difference in terms of graft survival. However, after the first 5-6 years, we do see suddenly the advantage of having added a pancreas transplant to the kidney because, now, 15 years later, these curves are statistically significant. This also is supported by the observation that recurrence of disease, diabetic graft nephropathy, recurs usually 5 years and later after a successful kidney transplant. So this is when the true benefit of the pancreas kicks in. It obviously kicks in with regard to control of blood sugar levels and so forth, but it really kicks in terms of protecting the kidney from recurrence of disease 5 years or later. Now, I made a mistake because I was talking about graft survival, I was talking about patient survival, but you now see exactly the same for graft survival. And as you can see, initially these lines cross, and then, the spread, it's just wider and wider 15, 18 years later. And as I mentioned before, obviously after 15 years, none of the living donor KTA kidneys in Minnesota that were considered to be too sick were still alive. This also shows you the long-term effect and benefit of the addition of a pancreas after a kidney transplant. So the pancreas after kidney in yellow, the KTAs in green or whatever color that is. And as you can see, throughout the years, the eGFR higher in the pancreas after kidney group. And over time, starting 5 years, you actually see more of a difference than you see initially. So the benefit appears to be a benefit after primarily a benefit after 5 years. But more importantly, look at this, the glycemic control, PAKs versus living donor KTAs. These are the hemoglobin A1C levels, patient with a functioning pancreas versus patient with a living donor kidney transplant. And no matter how hard they try, how much they are involved in intensive insulin therapy, this is what eventually kills them, or the consequences of the high blood sugar level. So the summary of that study was that pancreas after kidney does not negatively impact long-term kidney graft function. Pancreas after kidney results in better long-term serum creatinine levels and glomerular filtration rates. Again, you will see the benefit 5 years and later, more so than initially. And pancreas after kidney results in higher long-term patient and graft survival rates. Now finally, pancreas transplant alone patients. So remember, those are the non-uremic patients that do not require a kidney transplant. And as I mentioned, most of these patients actually come directly to us. They are usually not referred by endocrinologists. They read about diabetes and the treatment of diabetes, and because they are so desperate with regards to not being able to control their brittle diabetes, they usually contact us directly. Now, when a kidney is transplanted, it protects the simultaneously transplanted pancreas. We don't know why that is. But the creatinine level is used as a harbinger of rejection, and if the creatinine goes up and we start treating, and we get a biopsy and it shows rejection, and we start treating the kidney, we usually start treating the kidney before rejection is noted in the pancreas. It's more difficult in the solitary pancreas transplant categories, the pancreas after kidneys, because those are usually two different donors, unless you happen to do a living donor pancreas transplant and kidney transplant from the same donor. But by and large, you usually have a living donor or deceased kidney donor, and then you do a deceased donor pancreas, and they're from two different donors. So the kidney, because the kidney is from a different donor, cannot be used as a harbinger of rejection anymore. And the pancreas transplant alone group, you don't have uremia, which also is immunosuppressive. These patients reject the most. So this is why, I mean, even now, the results of pancreas transplantation alone still trail those of PAKs and SPKs. Now, because we use immunosuppression in these pancreas transplant alone patients, and some of these patients already have some form of diabetic nephropathy, they usually have to undergo, or they frequently have to undergo a kidney transplant at a later time. However, over the years, the percentage has decreased. If we look here at the number of years, look at 15 years, during the period of 1988 to basically 2001, about 40%, 2/5 of all patients undergoing a pancreas transplant later required a kidney transplant, because the kidney function was not only destroyed by their diabetes, but also by the side effects of the calcineurin inhibitors. Now this year, if we extrapolate it, I mean, it's going to be probably about 20%. So, and we have made progress, there is no doubt about it. But look at this. If we now look at the eGFR of the patient who undergoes a pancreas transplant alone, you see a huge, huge difference. So if we do a pancreas transplant alone in a patient with a GFR of less than 40, the chances of that person requiring a kidney transplant within 10 years after the pancreas transplant is 65%. So the kidney function really determines whether or not you require a kidney transplant after the successful pancreas transplant, because if the GFR at the time of the pancreas transplant alone was greater than 60, your chances of requiring a kidney transplant at 10 years is only 5%. So what that tells us is that brittle diabetic patients have to come early to us in order to get a pancreas transplant, and not wait until the GFR already looks bad and we are scratching our heads with our friends from nephrology whether the patient should have a kidney alone or a combined pancreas and kidney transplant. These are studies, seminal studies that Mike Maurer at the University of Minnesota with his team performed. So what it shows here is the glomerular basement membrane, the tubular basement membrane, and then he also looked at the mesangial fractional volume. For the non-nephrologists, the definition is provided here, and the mesangial matrix fractional volume. I don't want to go into it at a lot of detail, but when the first results came out and were published in the New England Study of Medicine, the results were such that kidney function deteriorated 5 years after a pancreas transplant. And everyone who was opposed to pancreas transplantation, particularly the ones that remember the days when we had a high complication rate and patients were dying, said, we always told you it's bad, 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 don't do a pancreas transplant. Then it took another 5 years to show this. And this really shows the true benefit. You're not doing a pancreas transplant to quickly cure diabetes and make all the symptoms disappear. You are doing it long term, because I mean it takes at least 5 years until you finally see the benefits and reversal of some of these changes. But this is just one of these slides, obviously one very impressive one that was part of that New England study of medicine. So, I mean, have we made an impact, or are we just holding at the moon? This is what we really have achieved. This is the estimated half-life, 50% function nowadays of a SBK, PAK, and PTA. Now look first at the pancreas in the SBK category, how it has improved from 110 months to 157 months. So this is 50% functioning at 157 months and beyond. So a huge advantage. The solitary transplant groups, the PAKs and the PTAs, we have seen huge progress within their own categories, but compared to the SBKs, these results still trail the results of SBKs. Now compare the pancreas in the SBK category with the kidneys. Again, if you look at 1 year survival, the results are actually comparable, 110, 112, 131, 143, 157, 160. So you may say, well, I mean, there's a slight advantage in favor of the kidney. However, if you look at the conditional numbers, first year technical failures excluded, look at that. Pancreas, almost 2 years better estimated half-life than the kidney. A few months here for the second time period, and now about 1 year longer half-life function for the pancreas than for the kidney. So those are tremendous improvements. We haven't seen the same kind of improvement over the last 10, 15 years with kidneys. We haven't seen it with livers, and we also haven't seen it with intestines. This is a true success story, but it really lies on us to get the message out, because there are not enough people that know how much progress has been made in the last 10, 15 years. So in conclusion, pancreas graft function in SPK and PAK recipients is significantly improved over time when compared to diabetic KTA recipients, irrespective of donor source. Obviously, when you look at the deceased donors, it's a no-brainer. But even with the living donors, even at 5 years, I mean, the SPKs have a higher patient graft survival rate. The native kidney function with normal GFR and PTA recipients is improved or stabilized when compared to non-transplant diabetics. If the GFR is already reduced at the time of PTA, the likelihood of a subsequent kidney transplant increases, and it actually increases significantly, as I have shown. A successful pancreas transplant reduces the likelihood of recurrence of diabetic nephropathy and progression of native nephropathy. Now, future improvements in none or less nephrotoxic immunosuppression will further enhance life and organ-saving benefits of a pancreas transplant, which we can say, I mean, for any organ. But I think, I mean, what was presented today by our colleague from Chicago and the introduction of new current immunosuppressive medications, belatacept and so forth, will continue in that regard. So I'll stop here. I thank you for allowing me to speak, and if there are any questions, we'll probably discuss them in a few minutes. Thank you.
I invite all the speakers to please come at the podium for a question and answer panel discussion. Please have a seat. Dr. Vidania, Dr. Bamboula, Dr. Markel. Yes. So we have a question in the audience. Yeah.
So I'm pleased to introduce to you an 18-year simultaneous kidney pancreas recipient whose last creatinine, Glenda just told me, was 0.9. So, but the question was, I recently sat in on a conference that the Transplant Alliance did that said, and this is for Dr. Grissner, one of the major reasons that pancreas transplants seem to be going down is transplant surgeons don't want to do them. They look at them, particularly the pancreas only, which might create a great cost to go recover them, but also because they take a look at them and they discard them for a variety of reasons, which are among this community that I heard, not quite known. They are potentially quite useful transplant organs. So what do we do about that?
Well, first of all, congratulations. And I must say, my wife is here. I'm not quite sure how many recipients are out there with graft function over 15 years, but I think, it's in the thousands now. And we also have patients, that have now enjoyed graft function for 30 years or more than that. To your question, I think several factors contributed. First of all, the people that coined the field, the David Sutherland, the Hans Sollenders, Rob Corries, and so forth, they all are no longer active and or have retired. So the second generation of pancreas transplant surgeons, unfortunately, were not as vocal and are not as vocal as the first generation was. The second, reason, I think, is something that we have to blame ourselves for. We have to be more proactive in terms of educating physicians, health professionals, and patients, diabetic patients, about what pancreas transplantation has been done. The third thing is islet transplantation and pancreas transplantation are frequently shown as competing procedures, and they are not. Islet transplantation can be considered, and as you know, islet transplantation, we still don't have reimbursement by private payers, and we don't have it by CMS either, which tells us that the results are not there yet. But islet transplantation is a procedure for a patient with a high surgical risk and who may die as a consequence of undergoing a major complex procedure such as a pancreas transplant. Pancreas transplants, on the other hand, for patients with low comorbidities is clearly, an excellent procedure. So the islet and the pancreas communities have not come together and made statements in that regard as to who should undergo or considered for an islet transplant and who should be considered for a pancreas transplant. The last reason that I want to mention, because I don't want to take too much time in that regard, is you're absolutely right. There are not that many surgeons, transplant surgeons anymore, that are adequately trained in pancreas transplantation because the numbers over the last 10 years have gone down. And pancreas transplantation is not just another kidney that you put in. Pancreas transplants are transplanted inside the abdomen, and it requires a fully trained general surgeon who has experience with gastrointestinal surgery, with vascular surgery, and really knows about, the complications that can occur inside the abdomen. So that has become a deterrent for surgeons. The final argument is the following. CMS reimburses about $1,800 for a kidney transplant, about $2,000 for a pancreas transplant, $10,000 plus for a liver transplant. That is why. Because a pancreas transplant with the bench work and everything takes about 3 times as long as a kidney transplant does, but you only get $200 more. So tell surgeons, and no matter how motivated they are, their chairman, their chief will tell them, hey, you have to work harder to make ends meet because you're not bringing in the money, that we are paying you. And that's unfortunately the truth that very few people talk about. But the incentive for doing pancreas transplants is not there as much as it is for primarily liver transplants or for kidneys because, of a much higher volume. So a very long and complex answer to, a straightforward question, but there are many reasons why it happens, but in the end we have to blame ourselves that we have not been more proactive, and I hope that will change again over the next 5 to 10 years.
Any other questions? I have a question for Dr. Zadania. Most of the BK nephropathy that you see, is the BK virus more donor-derived or more from the recipient? Or
I think that's a good question. I didn't address that in my talk. I think the data suggests that you can have donor-derived infection, usually presents early post-transplant. In our center, we haven't actually formally studied that. And I think the only data that they've done is with deceased donors, where they've looked at BKV positivity and then shown that those patients, recipients were at increased risk for BKV reactivation. So I don't know most, or because I don't think we formally studied it thoroughly to answer that question accurately. Oh, you have one? Okay. I said I didn't address that in my talk because we haven't formally studied it at our center, but there are data that suggest that you can get donor-derived BKV infection. Specifically in the deceased donor population, they've studied that. But I don't think that we've studied thoroughly enough to answer your question, which was, are more of them living donor recipient-derived or donor-derived? So I don't think that we've done that study fully.
And another question about the BK nephropathy. For IVIG, it looks like you're using that more in your center. Do you look at certain things on pathology to decide which patients will get IVIG, or?
So I think that we use IVIG more as an anti-inflammatory agent rather than as an anti-BK agent, because you saw the data that suggests that even if you do immune reduction preemptively early in the BKV infection course, you still have a risk of developing rejection. So we feel that as you're reducing immunosuppression, you treat with IVIG, which for the most part does not permanently increase your BKV titers and is associated with increased risk of nephropathy. So I think it's more of an anti-inflammatory agent. So in our pathology, if we have any signs of inflammation, we will use IVIG.
Yes, please.
I wanted to ask Dr. Grusner, I was interested in your slide where you had the pancreas alone, and you showed that a certain number of patients who had normal GFR required a kidney transplant. Because given that only a third of type 1 diabetics will ever progress to develop diabetic nephropathy, I'm wondering, did anybody look to see if those patients had microalbuminuria, or were those patients who actually had early stage diabetic nephropathy before they were transplanted, or did they somehow, is this calcineurin related? Or?
Well, we do it now, and I think we have a better understanding. Yes, I think it is all calcineurin inhibitor related. And it's also related because the pancreas transplant alone patients usually require higher tacrolimus levels early on than the PAK and SPK patients. But the interesting thing is that if you have a GFR of greater than 60, at 10 years, your risk of having to undergo a kidney transplant is less than 5%. So I think we have made progress in many ways in that regard, but there are still, a number of questions that, need to be resolved. Look, even here at Downstate, when there was an active pancreas program in existence, pancreas transplants were not alone, were not performed. It was always done in conjunction with a kidney or after a kidney transplant. So I think as we start building this program, we will have an opportunity to study these patients and follow them long term. And just a cross question with regard to the BK, I was very interested in that because we use more and more belatacept in some of our patients now. And we also see more patients with antibody-mediated rejection. We give IVIG, and you said IVIG may reduce the number of BK infections. So in patients with antibody-mediated rejection that got IVIG, do you actually see less BK?
Again, I don't know the answer to that question. That was an in vitro study that suggested that there is a decrease in BKV replication. But at the same time, in the literature, there are case reports suggesting that if you treated patients who developed BK viremia with IVIG, the viral load actually went up. Nonetheless, I think that happens to be transient if you look at the case report carefully, and then based on my clinical experience, the viral load going up is transient and not associated with progression of graft injury related to BKV.
We have a question from Dr. Tedler.
Yes, the question is for Dr. Markel. Do you think steroid avoidance or withdrawal is justified to favor healthy bone in transplant patients?
I think if it's possible, but obviously you have a risk-benefit situation there because dialysis patients' bones don't do too well. So, as Dr. Josephson said, you need to look at the patient in front of you and decide, is the steroid avoidance acceptable in that particular patient in order to help with their bone disease, or is it going to put the patient at risk for losing their allograft, which will probably make their bone disease worse than the steroids? So I guess there isn't an absolute all size. I think in the best situation would be to never have the patient on steroids, but obviously we know that we can't always do that.
Question from Dr. Salifo. Yeah.
Thank you, all of you, for a wonderful contribution to the conference. This is just, to follow up on the question that was asked about the pancreas transplants. When do you think SUNY Downstate will start doing pancreas transplants, Dr. Grusner, number one? And number two, if there is somebody in the audience who has a family member with diabetes, should they all come and see you for evaluation?
Actually, as you know, Mauro, we have started the process already. I asked Carrie to give me a list of all the patients that had a kidney transplant, either from a living donor or deceased donor, and have good kidney graft function. So this is the first step. And then, since endocrinology is also part of internal medicine, I think our endocrinologists will get involved in this field as well. We have two specialists joining us as well for the pancreas transplant program. One is Mark Laftavi, who was the Chief of Transplantation at the University of Buffalo, a sister organization of SUNY, for about 15 years and has had excellent outcome both for kidney and pancreas transplant there. So he will join us within the next 2 or 3 months. And then with your help, we are bringing on Dr. Pankowitz, who has been the medical director of pancreas transplantation and the chief of transplantation medicine also at Buffalo. So we are really making an effort to bring a team together so that in about hopefully 2 or 3 months' time, Carrie is going to put the application through UNOS, but I don't foresee too many issues there, that we really can offer it early next year. Whether it's the 1st of January, I don't know, but I think before March we will be there and hopefully we'll have done the first one. But we also, and Dr. Salifu and I have worked hard on that. With my recruitment, we have made a requirement to the hospital that we want a leading islet cell facility. So we will build over the next 6 or 8 months an islet facility to offer islet autotransplant. That is usually only for diabetic patients with chronic pancreatitis, and then eventually allo islet transplants for diabetic patients. So our goal is not just lip service to diabetics. We really want to make diabetes and transplantation of diabetic patients one of the major pillars of this institution. So medicine and surgery are working very closely in all of these projects together. It always takes time, patience, and persistence. But if we can complete what we have discussed, I think we can work to the benefit of our community that we serve, the borough, and also New York City, because if you look at the numbers, 2 transplants per million is just atrocious, and also compared to other states in the country. We just have to make life for our diabetic patients better. And obviously, unless you tell me otherwise, I don't think I ever regretted in the last 18 years that you underwent a pancreas and kidney transplant.
Dr.
And by the way, I mean, you were not asked to come here today, and it's staged. I mean, this is true, and I mean, this is just wonderful to see that diabetes can be cured, and it's not, I mean, something to live all your life with and eventually die from it. So this is great.
Dr. Grusner, can you please also make a comment on especially diabetic, type 2 diabetics, and how many of these 1,000 pancreas that are done every year, type 2 diabetics are, or how many of those pancreas?
How many of these pancreas are?
Out of all the total pancreas that are done, how many are type 2 diabetics especially?
Yeah, I didn't show that. Obviously, my wife with a registry, I have another 500 slides in that little thing, but the number of type 2 diabetics is increasing. We perform about 8% of pancreas and kidney transplants in type 2 diabetics. Now, these type 2 diabetics have to be lean, and they have to be on insulin, obviously, and they have to experience similar secondary complications as type 1 diabetics. But the old dictum that type 2 diabetes should not be treated with pancreas transplantation is wrong and no longer valid. We have also seen an increase in the number of African Americans undergoing pancreas transplants. So, I mean, there are many encouraging things that we have seen. We also have done transplants in children. Not very successful because the immune system of children is so much stronger than that of adults. Actually, the best results are seen in pancreas transplantation in the cohort of the 40 to 60-year-old. If you are less than 30 years old, you have a much higher risk of rejecting. And then obviously when you're over 60, where successful transplant still can be done, your life expectancy, when you do a successful pancreas transplant, it's not the same anymore as it is for a younger patient. So I think we will offer pancreas and islet transplantation for a variety of patient groups that are not considered mainstream at this point.
Thank you. Any other questions? Well, thank you very much for the panel discussion. Dr. Tedla for the closing remarks.
Thank you everybody for coming. This concludes this year's symposium. We would see you next year, and in the fall, in the spring, there would be the dialysis symposium. Please fill out your evaluations. We'll look at them and we would reassess our plans for next year based on your feedback. Thank you very much.